Feel free to stay close. You don't have to sit. Well, good morning. Thank you. We think this is the biggest crowd we've ever had for this event. Celebrate yourselves. I'm David Byrd. I'm a co-course director along with Dr. Evan Hall, who you'll hear from in a minute. This is and our virtual crowd is on as well, just so there's about equal numbers who are not here today. So double this crowd, which is pretty impressive. They'll have the ability to chat in some questions because if you've ever been on the virtual side, it's a very helpless feeling because you can't communicate very well. You all can communicate. So the people who show up in person, 80% of life is showing up. You're already in the 80% right now. I just want to give a few intro comments and you're going to hear some logistics from Dr. Hall. It is my absolute pleasure to welcome you to this event. I had the pleasure of starting this event 17 years ago. My first co-chair, does anybody go back to the beginning of this? Probably not. Yeah, so the first one of these, I had a co-chair, 16-year-old Katie Bunker, who had melanoma on her forearm, metastatic to lymph nodes here and lymph nodes here at age 13. Tough. We resected her disease. At the time, interferon was the only drug around. A lot of side effects, didn't work very well. 10 years later, she came back and told her story as a 10-year survivor. She's now a nurse. So luckily, she's not here speaking because nobody else wants to follow Katie Bunker. So we've been doing this for years and years. The theme of science to survivorship has been maintained because we think they're equally important and valuable in this journey that many of you have been on or are on now. So that's why we've kept the same theme. We've got a great group of speakers and you'll hear the agenda in just a second. We end this with patient stories. We have 2 volunteers who are going to tell their stories later on in the day. We deliberately have that at the end because they resonate the best with the people in this room. Most of you in this room have been through treatment or have family members who have. Some of you are still under treatment. And as you know, that is a roller coaster. However, in the last 10 years, that is completely changed in terms of what's available. And you're going to hear more about some even exciting advances now. So we're very grateful that you're here. We're very grateful for the support of the Fred Hutchinson Cancer Center and also for the Melanoma Research Foundation. You'll be hearing from them a little bit later. Because of that, we can use this room, which we've used from the beginning, and we continue to make this a free event. We just ask people to register. So we would like to continue that. I mentioned the patient stories because some of you in the audience have actually been storytellers here in the past. Some of you may be future storytellers. So please come up to us sometime today, either myself or Dr. Hall, and let us know if you would like to tell your story in subsequent years. So I just want to thank you and express my gratitude for you being here. And we're going to have a fun day today. Thank you.
This is us. I think it's also kind of hard to follow Dr. Byrd, so that's why I'm stepping in. This is an overview of what we have coming. So from science to survivorship, in the morning sessions, we'll focus a little more on science, medical aspects, dermatologic aspects of melanoma care. And then in the afternoon, we tend to shift more into survivorship. So we'll have talks on nutrition and integrative medicine and survivorship for melanoma. And then the patient stories. We'll have 2 talks, then a quick break for coffee and to use the restroom if needed, and then a lunch break from 11:30 to 12:10. So a couple comments. This event will be recorded. So just, if you're going to ask a question, it will be recorded. It's good to be aware of. To the virtual audience, if you use the chat function through the online Zoom feature, you'll be able to ask questions. We'll be monitoring that and we can ask the question in person on your behalf. We'll repeat that so that everyone in person can also be aware of the question. And then it should be fairly easy to rejoin the conference if you accidentally click out. Just click the link again. And then for the in-person folks, we'll plan to do questions at the end of each talk. We've built in some time for that. And we'll try to have you use the microphone so that the virtual audience can hear the question. And we really do take the feedback from this event seriously. It's the first thing we do when we think about planning next year's symposium is comprehensively review what seemed to work well and what ideas you all had to make the event better. So please fill out the feedback forms. It's very important. And we really appreciate it. Oh, we're not doing a break yet. That would be early. So the last thing I'll say is I just want to personally thank the speakers who've come on a Saturday on what's typically a day off to share their knowledge and information with you, our partners at the MRF and the audience, first and foremost. This is why we do this. It's for you, and it's great to see so many familiar faces that I've come to meet over the years here. Lastly, there's some informational tables out front. So the MRF has some great information. There's information about our Fred Hutch Skin Cancer Research Program as well. So feel free to check that out during the breaks. With that, we will get things started. So for people that are following the pulse of what's new and exciting in melanoma, you may have heard a little bit about what's coming, but it's really a pleasure to welcome Dr. Sylvia Lee to give our first talk this year. She is an associate professor in the clinical research division at Fred Hutch and in the division of hematology oncology at the University of Washington. She is a medical oncologist with a particular interest and expertise in the use of cellular therapies to treat cancer and has led our TIL program here for the last several years. And she'll be talking about a very new and exciting treatment for advanced melanoma, TIL therapy. Dr. Lee, thank you.
Okay, thank you. Hi, everyone. I'm Sylvia Lee, one of the medical oncologists. It's nice to see some familiar faces. Thank you to everyone for coming today. So I am going to be talking to you about TIL therapy, which is a new treatment that was just FDA approved for melanoma a couple months ago. And I like including this cartoon of a dinosaur. If you can't read the caption, it's a dinosaur with a sunburn because his arms are too small to apply the sunblock. But I also like including this because TIL therapy is sort of weird. It's actually a dinosaur in the field of immunotherapy. It really preceded our modern immunotherapies that we have. It's been studied since the late 1980s, 1990s. And so it's really taken a good 30, 35 years to actually reach FDA approval. So this has been something that's been around for a long time. It's really informed the development of a lot of our newer immunotherapies, and we're now actually finally seeing it become widely available to patients. And so it's sort of it's a new old therapy that we're really excited about, and it's changed and improved over the years. So just to review, like in clinic, when you're talking to people, when you're reading things about melanoma, we often like throw out these terms, T cells, white blood cells, lymphocytes, and it can be really confusing because 8th grade biology was a long time ago. So just to review, your blood comes from your bone marrow. So your skeleton is not just scaffolding that holds your body upright. It's actually a very rich organ that makes all your blood. And it makes red blood cells, which help carry oxygen to different parts of your body. It makes white blood cells, which help fight infections in your body, things that don't belong, and platelets, which help your body make blood clots so you don't bleed every time you have a cut. So we talk a lot in cancer these days about the importance of your white blood cells and what your white blood cells are doing to prevent you from having infection, but also now fighting cancer. And you may hear the term lymphocytes. So lymphocytes is one of the types of white blood cells that you have. And you have different types of lymphocytes. There are B lymphocytes and T lymphocytes. And sometimes we make it more confusing because we call them B cells and T cells. And there are many different types of T cells. So when we talk about immunotherapy, what we're really talking about are different strategies to activate your T cells and make your T cells better at fighting your cancer. So your T cells are really what the type of white blood cells that are most important in fighting cancer. There's some T cells that are good and there's some T cells that are bad. So there are cytotoxic T cells, T helper cells, which also have several other names, which are good in fighting cancer, and Tregs, which are bad. They're good in some ways, but for cancer, they're bad because they suppress your immune responses. And so when we're talking about T cells, CD8 T cells, lymphocytes, this is sort of the general scheme of what we're talking about. And there are also additional types of immune cells that are important in fighting cancer too. So TIL stands for tumor infiltrating lymphocytes. A long, long time ago, people did not think your immune system had any role whatsoever in being able to fight recognized cancer. And, oh, thank you. And the idea is that we know your immune system fights things that don't belong in your body, that are foreign in your body, like bacteria, viruses, fungal infections. And it does not make sense that your immune system would ever really be able to fight cancer in a meaningful way, because cancer comes from the natural tissues in your body. It is part of your normal body. So how could how could your immune system really play an important role in recognizing that as being something that should be rejected from your body? But even at that time, where there's a lot of skepticism about what your immune system could do, one of the early observations in cancer patients, including in melanoma, is when people were diagnosed and you did a biopsy and you saw, okay, there are cancer cells there, there were some patients who had a lot of T cells that were mixed in with their tumor. And there's some patients who had no T cells mixed in their tumor. And what was consistently seen across the board was that patients who had a lot of T cells mixed into their tumor at the time of diagnosis, they somehow had better outcomes than patients who did not have these T cells mixed into their tumor. And so that was one of the earliest signs that maybe these T cells are really important. Maybe they're seeing something important in your cancer, and maybe they're actually playing a role in what happens over the next years in your cancer. And that was really sort of the founding principle of trying to look at, well, what are these T cells doing and how can we help them out and make them better? And so Steve Rosenberg is considered the grandfather of immunotherapy. He operated out of the NCI, the National Cancer Institute, which is the same as the NIH. And what he evaluated is he did a lot of different things, but what he did for TIL is he experimented with resecting a portion of tumor from melanoma patients and trying to grow out those T cells that are mixed into the patient's tumor and seeing if he could grow it out into higher numbers that could then be used to help patients. So he designed this whole process where you resect a portion of the tumor, ideally at least 2 centimeters, 1.5 centimeters, and then you take little pieces of that tumor and you grow it out in these culture plates with high doses of IL-2. So IL-2 stands for interleukin-2, and this is something that naturally exists in your body. And it's a powerful food that causes your T cells to grow. And when you put in high amounts of IL-2 and mix it into these little tumor fragments, you can actually get the T cells to grow out. And what the process was back then is sort of growing these T cells out across a period of 5 weeks. And then actually there's this rapid expansion protocol that we really developed at Fred Hutch, and they used our protocol to sort of grow these out into the billions and billions of cells. So much higher than the number that would naturally exist in the patient's body to infuse back into the patient. And what he found is that some patients actually had regression of their melanoma when they got these T cells. So this was the first sign that you could actually use someone's T cells to cause someone's cancer to shrink and get better. And these are pictures actually from our labs, actually downstairs right below us. We have our cell therapy labs where we have grown these T cells for our patients for our clinical trials. So I think the next slide has, actually, no, that's the 2 slides away. I just want to give you a warning if you don't like pictures. So just a reminder, TIL stands for, like, TIL sort of used interchangeably with T cell, which is a type of white blood cell. Okay, so TIL is not, in its current form, it's not just giving someone the T cells. You actually have to give it with several different things. So when we say TIL therapy, what we're really talking about is 7 days of 7 days of chemotherapy with cyclophosphamide and fludarabine, and this is we refer to as lymphodepletion. This chemotherapy is very intense, and it is not chemotherapy that is given to actually fight the melanoma. It's not effective in fighting the melanoma. But what we understand is that if we do not give this chemotherapy before the T cells do not work very well. We know that one thing that melanoma and other cancers do when it is growing in a patient is it actually sets up a bad immune environment in the patient that is suppressive to the good cancer-fighting T cells that your body may have some of. And it's actually a pretty incredible thing that the melanoma is able to protect itself from your immune system by sort of setting up these sort of defensive shields around itself that shut down your immune responses. And so we understand that if we give patients this lymphodepleting chemotherapy, we can wipe out a lot of those bad immune cells so that when we give these cancer-fighting T cells, they actually have a better chance of getting into the tumor. They can get past these defenses and they do better. So this is an important part of giving TIL therapy to prepare the body, wipe out the bad immune environment. And then the other thing that you're doing is you're dropping, by decreasing all these bad immune cells, you're reducing the competition in a patient's body for the food that T cells need to grow. And so when you then infuse the T cells into patients, they aren't competing with all these other immune cells for all the food, and they have an advantage and they have all this food available to them in patients' bodies. So that's what the lymphodepletion is for. It's 7 days of chemotherapy given in the hospital. It's very, very intense. Then you get the TIL infusion, which is actually just a few hours. It's the easiest part of this whole process. And then you follow it with IL-2. And so again, IL-2 is something that naturally exists in your body, but we give patients super high doses of IL-2. And what it does is it's a powerful food for the T cells. So the T cells are a little bit stunned. They've been grown out in a laboratory, stored in a bag that looks like a blood transfusion bag, frozen down for shipment back to the patient. And they're sort of stunned and they need to wake up. And so when we infuse the T cells into patients, we find that if we follow it up by giving them a ton of food, it sort of wakes them up, stimulates them to start growing, making copies of themselves. They're a lot healthier and they do better. The IL-2 is given to patients in the ICU. So all of this treatment, these 3 different stages, occurs in the hospital across about a 12-day hospitalization for most people. Okay, sorry. I meant to warn you before this picture, and then I completely forgot. But you can close your eyes if you don't like looking at pictures. This is there's a lot of data from the early days when we looked at TIL that showed how patients were responding. This is one of the early pictures from a patient treated at the NIH who had metastatic melanoma, and one of the sides of his melanoma was growing in the back of his head, and it was growing too invasively into his muscles and his skull for surgeons to be able to resect. And so he was one of the early TIL patients, and he had a complete response actually to TIL. And so at that time, people thought when you have really bulky disease, there's not much you can do. But he had basically a few months after he got his TIL infusion, that mass started necrose. It started getting blacker and blacker. And one day it just fell off his neck onto the floor, and his tissue sort of healed underneath it. And then 30 months later, he had no evidence of that melanoma and had a complete response. So the first trials, again, were done at the NCI, the NIH. They really pioneered this whole strategy. And they were seeing about 50% response rates overall. A complete response rate was 12 to 20% of their later trials. And then other institutions started trying to do the same thing and growing T cells themselves at these other institutions. And the really phenomenal thing is that the response rates at different institutions were almost exactly the same as the NIH, where everyone was seeing 50% response rate and about a 12 to 20% complete response rate. And we had our own TIL therapy trial too with David Byrd 10 years ago, and we grew TIL on 30 patients. We treated 10 patients here, and we actually, even though the numbers are small, we had the exact same response rate, 50% response rate. 2 of our patients had complete responses, so 20% complete response rate. So this was very reproducible across institution. But the problem is every institution has to have their own TIL lab, their own cell processing facility, their own staff that are trained and learn how to grow these T cells on patients. And that is something that is really hard to scale when you're thinking about how can we make TIL available to all melanoma patients in the country and in the world. You can't, that's not really feasible for every cancer clinic to have their own lab growing TIL. And so from this early work, there were companies that started to develop that were interested in how can we streamline this process. And Iovance, I think there's some representatives from Iovance here with us today. They were one of the early companies that started looking at how can we develop a centralized facility where the model is patients don't have to have they don't have to go to a place with their own cell processing facility where you have people growing your TIL, but you get surgery at your cancer clinic. That tumor specimen, you get your tumor harvest, remove a portion of your tumor, and then it gets put into containers on ice and then shipped across a 24-hour period, let's say FedEx, to a central facility where they handle all the TIL growth across several weeks and then get the TIL product and then FedEx it on a plane back to the patient to get the treatment. And that is the current model that started to get developed. And then more institutions were like trying to start studying how can we support the sort of centralized process. Then what happened that sort of changed the landscape is the immune checkpoint inhibitors were developed. And so around 2014, 2015, these immune checkpoint inhibitors, and so what we mean by immune checkpoint inhibitors are these are the medications we commonly hear about when we talk about immunotherapy, nivolumab, pembrolizumab, ipilimumab, or what we mean when we say immune checkpoint inhibitors. These were developed and we started seeing incredible responses for the immune checkpoint inhibitors. And these are medications that also activate a patient's naturally existing T cells to try to improve their ability to fight melanoma and other cancers. And the responses are pretty similar to what we're seeing with TIL therapy, where for one PD-1 immunotherapy like pembrolizumab, the response rate is 43%. When you do combination, it's up to 58%, but around half of patients we're seeing responses, and the complete responses are very similar too. And so this is an off-the-shelf product. You don't have to take a patient through surgery. You don't have to grow their T cells out. And it's sort of doing the same thing. And so this was thought to be, wow, this is a lot easier than TIL. You can just give people this medication. And so that raised the question, okay, have we just come up with a better way to do what TIL is doing? Is there a role for TIL anymore? Or is TIL therapy just redundant with these immune checkpoint inhibitors? However, you know, with these great responses with immune checkpoint inhibitors, with about 50% of people benefiting, there are also about half of melanoma patients who are not having these long-term responses from the immune checkpoint inhibitors. So we were seeing a lot of people who went on these immune checkpoint inhibitors. They did not benefit and were wondering what to do next. And so this led to a new wave of TIL trials to test TIL on patients who did not respond to the immune checkpoint inhibitors, whose cancer progressed. And this is really the pivotal landmark TIL trial of melanoma patients who had 100% had progressed on PD-1 immunotherapy, 80% had progressed on our other immunotherapy, ipilimumab. And if they had a BRAF mutation, they were required to have progressed on BRAF therapy. So these are patients who had been on every meaningful treatment we have to offer for melanoma. And I am a believer in TIL therapy. I've been involved in it for many years, but even I was very surprised in a wonderful way to see that the response rates were so good in these patients who had really progressed on these other T cell strategies. And so we're seeing from this trial run through Iovance that the response rate in these patients was 31.5%. There were 3 complete responders. Interestingly, in people who were primary refractory to nivolumab and pembrolizumab, so people who never responded, they just progressed right through. They had an even better response in the average patient of 41%. And then the other really fantastic thing is that these responses were lasting. And so 43% of patients who had a response were ongoing at greater than a year. There's now a larger pooled analysis of these patients and an additional cohort of patients of 153 patients who were treated in the exact same way, who had progressed on all of our other immune therapies, BRAF therapy, that in that pool of patients, there were 8 complete responders, 40 partial responses, so a same overall response rate. And those patients have been followed for now at the last data cutoff 28 months. And the median duration of response has not been reached yet for that cohort of patients, meaning that they're responding too long to actually calculate a median yet, showing that these patients are having these long-term responses beyond 18 months and beyond. So based on this data, the FDA approved TIL therapy. This product that is called Lifileucel is the generic name, Amtagvi is the brand name, generated by Iovance Biotherapeutics a couple months ago. So a lot of people were surprised by the benefit of TIL therapy because it is really acting on the same patient's T cells that nivolumab, pembrolizumab, and ipilimumab are doing. So why would TIL have these responses in patients who didn't respond to these other immune checkpoints? And the reasons that TIL are distinct is partly because when you're giving someone pembrolizumab or nivolumab, you're taking the patient at sort of their baseline, how their immune system exists, and then you're giving them these medications every 3 weeks, every 4 weeks, and you're slowly activating their T cells. But when you do TIL therapy, you are actually infusing a huge number of T cells all at once. So the dose and the kinetics of the T cells that are suddenly being introduced into the patient is much different from what you're doing with sort of slow burn of the immune checkpoint. So there's a difference in dose of the T cells. There's also a difference in the T cell composition. When we look at what T cells are in the patient's tumor at the time of that tumor harvest, that resection that's used to grow out the T cells, and then we look at the T cells that are grown out in the laboratory, there are differences. So some T cells grow out better in that process, and some T cells sort of die off in that process. And so we think that we're actually enriching for T cells that are healthier, more capable of recognizing the melanoma. Another part about TIL generation is that we also see T cells that are activated. So the problem that we often see in patients after they've been exposed to and treated with these immune checkpoints is their T cells can become exhausted with time. They can sort of react at first and then they just fade out. And what we see in this TIL generation process is they start becoming younger, they start becoming activated and more energized in that growth process in the lab. And then the final thing that I think is really important is that when you do TIL therapy, you're doing it after that lymphodepleting chemotherapy. So you're wiping out that bad immune environment to give the T cells an advantage when you're infusing them into the patient. So that's something else that's really different between TIL therapy and the immune checkpoints. When you look at toxicity of TIL therapy, so the toxicities of TIL itself, like the TIL infusion, are very minimal. Like people tend to get fevers, chills, fast heart rate. They last for a few hours, but they're really gone after that infusion period, after a day. The majority of the toxicities actually come from the chemotherapy itself. So this is no joke chemotherapy. It is very, very intense. It causes people's blood cells to go down extremely low, which is actually our goal because we're trying to we're trying to wipe out those bad immune cells, but it also causes your immune system to become very weak because we've wiped out also the immune cells that are helping you fight bacterial infections. And so people are immunosuppressed, they're vulnerable to infections. And they can have, one of the risks is they could have a life-threatening infection. So we're putting people on antibiotics to protect them from that. We have special procedures if they start getting an infection to put them on IV antibiotics. People have a lot of nausea and vomiting, especially the first 2 days of chemotherapy. There are byproducts of the chemotherapy that can cause toxicity to the bladder. So we're giving them a lot of hydration to flush out the byproducts of the chemotherapy to try to clear it from the body. You can have diarrhea. You can have extreme fatigue. And so people are really wiped out from their chemotherapy, and that lasts for months and months. People are usually very tired for the first month after their TIL therapy. They feel better the second month out, third month they're out, but really it takes 6 months before they really feel like their normal self again. So it's very intense. The IL-2 is its own beast. And so IL-2 is when we give high doses of IL-2, it's like we're creating a state of sepsis in your body where you're fighting an overwhelming infection. It causes your blood vessels to be really leaky. And so your blood pressure is dropping, your heart rate is really, trying to keep up with that. Your kidneys can go into kidney failure actually because they aren't seeing enough blood. And sometimes that fluid leaks out of your lungs and you can have edema in your lungs and have a hard time breathing. So we have to give it in the ICU where we can monitor how all your organs are functioning and support people through that. You can have abnormal rhythms to your heart. So it's a period of very close monitoring where we watch you very carefully in the ICU. Giving people TIL, it's one of the most intense things that we can do to patients with the chemotherapy and the IL-2. So in our clinical trials, there have always been very rigorous screening processes to make sure you're eligible and you're fit enough to get TIL therapy. And now that it is FDA approved, these are things that we will still have to be doing, make sure that we're giving TIL to people who are strong enough to get TIL. We're now no longer giving, we used to give 14 doses of IL-2, and what we found with TIL therapy is that actually 6 doses are all that's needed, and we sort of give it up to how well the patient tolerates it. Some people tolerate 3 doses, some people tolerate all 6, some people tolerate 1, and then we stop. The interesting thing about the toxicities to TIL is that compared to the immune checkpoints, where the toxicities that you can have to pembrolizumab and nivolumab can really develop across, most of them might develop across the first 3 months. Some can develop across the first 6 months. Every once in a while we see toxicities, beyond 6 months. But the toxicities to TIL, they're very, very intense, but they all seem to happen during the month of TIL therapy, those 2 weeks, 3 weeks after they get their lymphodepleting chemotherapy. And then it's very rare for them to develop new toxicities afterwards. And so just to show you how this maps out, I have like this green box sort of showing this month of treatment is where all the toxicities occur. It's extremely rare to have late toxicities compared to sort of the timeline of how long we have to watch people for new toxicities on the immune checkpoints. So it's sort of a intense treatment. It's all comes at once, and then the rest of that period is recovery time. Okay. So TIL is not for everyone. The FDA indication is for advanced unresectable melanoma, metastatic melanoma that has been treated with PD-1 therapies. That's nivolumab, pembrolizumab, atezolizumab. And if the patient has a BRAF mutation, they have to have been on a BRAF inhibitor. So that's like encorafenib, dabrafenib, vemurafenib, brand names BRAF, Tovi, for those. You have to be very fit to get TIL therapy. So when you take someone through that chemotherapy, TIL, and IL-2, it's sort of like you're making them for a period of time 20 years older than they normally are and putting them into multi-organ failure for a period of time. And so to be able to tolerate that, you have to be really fit so you can survive that and then come out of that. If you are at a place where the melanoma is causing organ failure already, or if you already have problems from just life where your heart is not doing well, you're already having issues, or you're 85 years old and you're dealing with melanoma, if we make you 20 years older, that is not something that you can survive. And so this is not for everyone, unfortunately. You have to be in a place where you are fit enough where we can knock out all of these things. You still have enough remaining fitness where you can get through this treatment and come out. Otherwise, we will do more harm than good. So I try to manage people's expectations that you cannot get TIL and do well on it if your body is already struggling against other challenges. So you have to have a performance status of 0 to 1. What the 1 means is basically someone who is up and about, not confined to a bed or recliner, at least 50% of their waking hours, able to do light chores in the house. They might not be able to do strenuous activity, but they might be able to do some work activities, do laundry, dishwashing, and sort of not be debilitated where they're sort of lying in a recliner. So that's sort of the definition of having a performance status of 0 to 1. You also have to have a site of surgery that we can resect a portion of your tumor safely. And so the best places are like if people have lymph nodes that are easily reachable. Sometimes we resect from their lung, sometimes we resect from their liver. Bone is not it's not a good place to resect from, but it's really nice if they have something close to the skin where you can just do an easy surgery and resect a portion of their tumor without sending them back. The other challenging thing about TIL therapy is it takes a long time to get someone to treatment. So it takes a long time, like once you identify, okay, this person looks like they're good for TIL, you have to go through the scheduling, you have to go to insurance approval. Our insurance specialists are predicting that is based on our other T-cell therapies that have been approved for lymphoma and leukemia, that process could take 4 weeks, because you have to get 2 weeks to get your insurance company to agree to TIL, and then there's 2 more weeks to sort of negotiate the finer details. Then you have to get surgery, and then it takes about 3 to 4 weeks to actually grow your TIL, get it back to Fred Hutch so you can be treated with that. So all of that takes a lot of time, meaning TIL is not a good option for someone who needs treatment now, where they need to be on something in the next few weeks because their clinical status is changing very quickly. The other challenging thing about TIL is that patients have to put their life on hold for 1 to 2 months. So as I said, it is very intense. It's not something that you can keep a job through. People have to come to Seattle for treatment. They have to get the surgery, recover from the surgery. And then when they go through the chemotherapy, the TIL, the IL-2, that really wipes them out and makes them feel very tired. And to get T-cell therapy here, you're required to be able to stay within a 30-minute driving distance of Fred Hutch for a month after the T-cell infusion. And we do require that you have a caregiver who can stay with you to help if you run into problems and need someone to call clinic to get help. And you're being monitored very closely in our immunotherapy clinic for that month. There's some people who start doing better, they recover really well at 2 weeks or 3 weeks. And some of that time is negotiable, but for people who are signing up for TIL, we ask for their commitment that they can stay within 30 minutes of Seattle and have a caregiver, a spouse or sister or brother or a friend who can stay with them during that time. And then the price tag of TIL, it is not cheap. So the price tag of TIL is at $515,000. This doesn't even include all the other aspects of your care, including the surgery, the chemotherapy, the hospitalization, the IL-2. And so this is a very, very expensive treatment. It's because it's FDA approved. Insurance companies are being asked to cover for this. But there are also additional expenses of covering lodging while you're in Seattle, coming to Seattle, co-pays. There are things to alleviate some of those costs. We have subsidized housing here that's cheaper than staying in a hotel. And Iovance has a patient assistance program for people who meet that criteria to help with copay, to help with some of the travel and the lodging expenses. Okay, so the next thing that we're thinking about is we're already doing a lot of experiments for how can we make TIL better. So as you saw on the other slide, there's a 31.5% response rate. And we want to improve that. And so different things that are being investigated in clinical trials now are trials that are trying to improve the specificity of the TIL cells to recognize recognize the patient's melanoma better, and also how to improve the function. So there's a lot of different research in trying to get these T cells to be more effective in fighting cancer. One area that's really exciting is there's a group at the NIH that looked at the difference between patients who got TIL who had exceptional responses, who had complete responses, compared to patients who got TIL and did not have as good responses. And they found that the patients who had complete responses to TIL, when you look at their TIL, they had higher numbers of these special types of stem-like TIL cells that had certain characteristics. CD39, CD69 negative markers were what were identified. And so there is research now on looking at how can we grow TIL in a different way to enrich for these more effective T cells to give to patients. And so one company that's doing that now is Lyle Immunopharma, which is local, and they're growing TIL by changing the TIL generation process to try to enrich for these enhanced TIL to give to patients. Another area of research is looking at how can our successes in melanoma benefit other cancer patients. And so there are trials exploring TIL in other cancer types that are showing success in lung cancer, cervical cancer, breast cancer, head and neck cancer. So melanoma has really led the way in developing this for other cancers. So final points, TIL therapy is the first T cell therapy approved for a solid cancer. So this is a huge deal in this field of immunotherapy. We talked about the FDA indication for lifileucel or Amtagvi for melanoma patients. Again, there are restrictions for who can get TIL. Hopefully, as our methodologies improve, this will improve and we'll be able to offer TIL to more patients in the future. And then this is just the beginning. This is not the end of the road. We're looking at ways to improve TIL, make it better for future melanoma patients. We have several trials that are showing promise, and hopefully in the coming years, you'll hear about advances in TIL therapy. This is, some people like sort of wonder, what is actually going on? What does it look like? This is a video. It'll be a miracle if this works. So this is a little T cell. This is a cancer cell. And it's interacting with a cancer cell and recognizing it and sending material into the cancer cell that causes a cancer cell to die off and implode. Oh, and my last slide, I can't skip, is my thank you slide. And so, so these are patients who were treated on our TIL trial 9 or 10 years ago now. And the astonishing, amazing thing about them is that the majority of these patients participate in these trials, not only with the hope that they would benefit from them, but really with the sense of mission that maybe one day their experiences on these trials would help patients who are in the same boat in the future. And that future at that time, 9 or 10 years ago, was sort of very nebulous, sort of like maybe one day people will benefit from what we learn from this experience. And the thing that's incredible is that day is now, that, you know, we now have TIL therapy that's approved thanks to the patients who really took a leap of faith and participated in these trials when less was known about them. And so what inspires Dr. Byrd, Dr. Hall, and I, and all the providers is the incredible commitment that all of you and, you know, as patients and family members have in being part of this mission to advance the field. So thank you. Thank you for joining us today. I'm sorry. Did I save for questions? Or did you...
I think in the interest of time, we're going to move along. Thank you for a wonderful presentation. Yeah. Oh, that was very exciting. I think intense maybe is the word I would describe, but very, how remarkable to see that come through the journey it's been through. All right, so now moving from advanced disease towards the idea of skin hygiene and monitoring the skin after melanoma diagnosis. I'm very excited to introduce Dr. Anna Cogen, who's an assistant professor in our Department of Dermatology at University of Washington. She is a dermatologist who sees patients in the Fred Hutch Dermatology Clinic regularly. We have seen some of you. And she's really interested in complex medical dermatology and skin cancers. So it's really exciting to have her talk to us today about what you might be able to do after a melanoma diagnosis to protect yourself from the sun. So Dr. Cogen.
Well, first, I just want to say thank you so much for having me here today. This This is such an honor to be here to talk to all of you and talk about something that is near and dear to my heart. As Dr. Hall mentioned, I've been at University of Washington Fred Hutch for about 5 years now, and I work in both places. So it's a joy to be part of people's care and their journeys. So this is a topic that I talk about with many of my patients about how to protect ourselves, before, during, or after a diagnosis, or when somebody's loved one, family member, friend has a diagnosis. So it's just some things to think about. So here's sort of a list of topics. I always find this is helpful. I'm going to talk just really briefly about what skin cancer is and some of those risk factors. I'm going to talk a little bit about the sun and UV light and how that affects our skin, as well as things that we can all do to protect ourselves. And then I'll briefly talk a little bit about what we call secondary prevention. So when somebody has had a diagnosis, what, some of the tools we can use going forward. All right. So what is skin cancer? Right? We use this word, we throw this word around, and sometimes it actually is a little bit confusing, but just to really clarify and get down to the nuts and bolts. Cancer is really defined as when a cell grows in an uncontrolled manner, right? And it has this potential to go other places. And skin cancer is specifically when there is a skin cell that begins to grow uncontrollably and hence spread as well. And there are many types of skin cancer, and melanoma being one of the types of skin cancer. And the type of skin cancer is really contingent on which skin cell is growing. So I made this beautiful graphic. Please excuse my artistry. It is not one of my strong suits, but the skin is actually a complex, amazing organ that is an immune organ in and of itself. And it's made of, we really think of it as in 2 layers. And so we have this top layer of skin that we see called the epidermis. And these are these green cells. And these are made of multiple cell types, including these keratinocytes. And then this blue cell here is a melanocyte. So that is your pigment producing cells. And then below the epidermis, we have the dermis. And that has a whole other host of these inflammatory cells, these T cells that Dr. Lee spoke about. It has blood vessels. It is also sort of a complex place in which we have a lot of immune cells. So as I mentioned, the blue cells are keratinocytes. And here's an example of a melanocyte. And a melanocyte is the cell, as I mentioned, produces pigment and can turn into a melanoma. Okay, so why do individuals get any skin cancer? Well, this is actually a very complex question too. And I'm going to and there are many reasons, but one potential reason is from damage to these cells, external damage. And this external damage leads to mutations of the DNA in each of these skin cells. And that damage can then make the cell grow uncontrollably. Normally, these cells have checks and balances, and that can kind of stop that check and balance and have it keep growing. All right, so when we think about skin cancer, this is just the basics. We sort of divide it into 2 categories. We think about melanoma and non-melanoma skin cancers. And while this is a gross simplification, I think it helps us really think about, how we treat these skin cancers and what our options are. It also tells us how important melanoma is. And all of you know that melanoma is incredibly important and sort of brings that point home. Non-melanoma skin cancers, there are many kinds, but the 2 that we talk about the most are these basal cell carcinomas and squamous cell carcinomas, which I won't be discussing today, but just to have that framework when we're thinking about skin cancer. All right, so we talked about this external sort of stimulus or mutation, the thing that can cause a mutation. And one of those things that can cause the skin cells to mutate is UV light. And so there are several types of UV light, but the 2 relevant types of UV light in our world are the UVA or ultraviolet A and ultraviolet B. In our ambient light, every single day, we are exposed to 95% of ultraviolet A. And I'll tell you why that's important, and less than 5% of UVB. And they penetrate the skin in different capacities, and some are associated with skin aging and some are associated with skin burning. But the most important point of this is that both types of light can cause skin cancer. We used to think that skin cancer was predominantly caused by UVB, but we have since learned that that is actually not the case. So, and UVA can also be responsible. All right, so let's talk a little bit about risk factors then. So we talked about one of the big ones of ultraviolet light, and this includes indoor tanning and sun exposure. Ionizing radiation, certain chemical exposures can also be a risk factor for skin cancers. People who have chronic ulcers, chronic scarring, the human papillomavirus as well has been associated. Genetics have been associated, our skin type, people with numerous abnormal or atypical moles, as well as immunosuppression. So those patients who have had an organ transplant per se, and their immune systems are not able to sort of fight cancers as easily. All right, so the question always comes to me, should we get a base tan before going on vacation? Is this gonna help us? I feel like the audience knows the answer to this question. I love it already. And this is an example of a tanning booth. And I just want to say that I have never been in a tanning booth, not because when I was in high school I didn't want to, but because I was too lazy. So thank goodness for laziness. Sometimes it's helpful. But the answer to this question, as many of you have realized, is no, we should not get a base tan. Tanning means that our skin is reacting to that UV light and trying to protect us. And interestingly, tanning beds are primarily UVA, so which is why we used to think that they were okay. And then we realized that UVA is not good for us. So with that, there is no such thing as a safe tan. And I hate to say that. And if I get tan, I won't tell my dermatologist. So. But the next question that comes up is, do we need sunlight for our health? And we say, okay, so you don't want me to be tan, but what about the health benefits of sun? And nobody is wrong for asking this question, and it's an important question. So I want to just touch on this briefly and explain why it's still okay to use sunscreen. So there are benefits to sunlight. Sunlight, the UVB, which I remind you is less than 5% of the light that actually touches our skin or in the ambient world here, converts a compound in our skin to pre-vitamin D, right? That pre-vitamin D then goes to the liver and is converted and then goes to the kidneys, and now it becomes our active vitamin D in our body. So you might say, wow, well, we really need this UVB, right? We better not put sunscreen on because we're trading one thing for another thing. But another way to get pre-vitamin D is from our diet. And actually the FDA recommends that we actually get vitamin D from our diet and not from the sun for many reasons. But vitamin D is really helpful for us, right? I don't want to pretend that this isn't helpful because it's important. It is important for our bones. It's important for our immune system. It's important to regulate inflammation and homeostasis. So it does a lot of critical things. But what if we don't get sun? Is that going to affect our ability to get vitamin D? And the answer is no. And you might be surprised by this. And I was surprised by this until I started reading more and doing the research and literature. But there have been numerous studies that showed that sunscreen is not associated with low vitamin D levels. And I've just got that. That's an amazing idea, right? Because we all think, well, I better go get my vitamin D for the day. But that is actually, interestingly, not the case. There have been studies looking at, so we know vitamin D is important for our bones. They have looked to see of bone health in people who use sunscreen, and it was not affected. And there's a lot of reasons why. And part of the reason is that the amount of UVB, that second type of UV in the atmosphere that get to our skin is so low that it is probably not the main responsible factor for our vitamin D. The other reason is none of us use as much sunscreen as we could, well, myself included. I just outed myself there. So, and sunscreen is imperfect. Sunscreen lets some UV get to our skin. So if you are using sunscreen, know that you are still getting your vitamin D or activation of that. And I read some different recommendations, and it suspects that, the data suggests that we only need really 5 to 15 minutes of ambient sunlight on our arms, maybe 2 to 3 times a week, and that is sufficient. That means walking to get our mail, taking our animal for a walk, going to our car here and there to the store. That is probably all you really need. All right. So with that, I'm going to now move on. How do we protect ourselves from the sun? Now that we know that it is safe to do so. There are so many ways to do this. We can be under shade. We can use clothing. I am a huge proponent of clothing. And actually, they say the brighter the color of clothing, the more it protects you from the sun. So it absorbs more of the sun rays. So thicker clothing, brighter clothing, darker clothing are all great. You do not have to buy a UPF clothing. I want to say that it is, I love it. You don't have to get that. You can use your own clothing that you have. Hats are great. Long pants are great. There are swimwear now that are long pants. My family makes fun of me for wearing them, but I love them. They have pockets, so we all know how important that is. Sunglasses are really important too, right? Our eyes are exposed to the sun. Sunglasses actually only provide a small amount of UV protection around our eyes. I just saw a study that it was like, it's SPF 10 or 15 maybe, but it's still, every little bit helps. Shade's important. And I wanted to take a moment to talk about shade. I love shade, but it is not sufficient, sadly. But shade is wonderful. Indoors are wonderful. Trees, umbrellas, tents, do all those things. Unfortunately, sun loves to reflect off of the snow, off of the sand, and off of the water. And in fact, I saw, and I think I'll talk about one recommendation from the EPA, the Environmental Protection Agency, that if you are somewhere near snow, you are doubling your UV index. I know, I get mind-blowing, right? So we are in Washington State and we think, oh, we're so protected. There's no sun here. Oh, au contraire. So, and the other thing I like to point out is glass. Now, glass filters out UVB, but remember, UVA is 95% or probably maybe more of our UV light. So if we are inside and we are sitting next to beautiful windows and that sun is shining on us, we are getting UVA. If we are driving in our car for long periods of time, people who do a lot of driving tend to get a lot more sun exposure on the left side of their face, the left side of their arm. And so you will see people who drive a lot, they will be wearing a sleeve. So next time you're driving, look at people who are sort of, driving as a career in trucks, and sometimes you will see them wearing sleeves to protect their arm. Often their arm is outside of the vehicle, but good for them. I'm really proud. So there was a study done actually, because I think being data-driven is really important, right? We can make all these statements, but do we really know? So there's a studies done, and they put sensors in the shade and they put sensors in the sun. And they found that even in the shade, there was UV detected. And so that was just an example of one study that sort of brings that point home. That said, the shade has so much less UV. So still go in it. It's great. It really helps, but it's not the only thing you need. So that brings me to my favorite topic, is sunscreen. Sunscreen is something that we all love, and especially in dermatology. We talk about it all the time. In fact, one of my colleagues gave this incredible talk on all the different kinds of sunscreen, which I don't have time to talk about today. But we talk about sunscreen in terms of its sun protection factor. And this is essentially the factor that tells us how much the UV is being filtered out. So SPF 15 filters out, if used correctly, which is very hard to do, 93% of the UV rays, and SPF 30 filters out 97% of the rays. So that shows you that even if you slather yourself, you are still getting UV with sunscreen. And as I said, that's why you still get all the vitamin D benefits of SUV even with a full body sunscreen. Maybe if you like took a bathtub and you dipped yourself in the sunscreen, I don't know how how much UV you're going to get then. But I wanted to put this up. This is from the spotSkinCancer.org, and this is on the American Academy of Dermatology website. And this is about how to select a sunscreen. I apologize for how small the writing is, but some of the big things to think about is something that says broad spectrum, making sure it says it's SPF 30 or above. That's what I tell everybody, 30 or above. And broad spectrum means both UVA and UVB. And water resistance, very helpful. And you can go to that website and look, kind of read a bit more. But I want to point out what the recommended amount of sunscreen is for the body. And this is also kind of amazing. So if you take a shot glass and you fill it up, that's 30 milliliters. That is how much is recommended to one application for the body. So that's a lot. I am not good at that, but I try my best. All right. So we talk about, there's two sort of big categories of sunscreen. There's chemical blockers and physical blockers. So this is a question that we get a lot. What's the best sunscreen? Well, let's talk first about what these are. So chemical blockers are sunscreens that have UV, that absorb the UV rays and convert them to heat. And these are the ones you can rub into your skin. They don't create any residue, and they have all these amazing active ingredients. And sometimes people who have sensitive skin don't tolerate this kind as well. There have been questions about reef safety, and actually that data is very mixed. But if you go to somewhere like Hawaii, they're only going to sell reef safe sunscreens, and you can look to see about which sunscreens are reef safe. It just includes one of those, doesn't include one of those active ingredients. Physical blockers, on the other hand, reflect the UV rays. And so these sunscreens tend to be those like really pasty white ones. I love them. In my family, maybe not so much, but these include zinc oxide and titanium oxide. So these don't absorb in the skin. These stay on the surface of the skin, and they're almost like wearing clothing. Okay, so one question I get is, how often should I use sunscreen? Daily. So, and one of the important things to think about is thinking about where you are, what the UV index is, and like what your activities are going to be that day. Sunscreen lasts 2 to 3 hours. So if we put it on at 8 a.m. by noon, you essentially have no benefit from that anymore. So yeah. So people make fun of me. I'm in clinic and then I reapply and I'm like, guys, it's time to reapply our sunscreen. And I know that none of the residents I work with roll their eyes at me. Maybe they do. And then the other thing I just want to point out is to be really diligent around snow, around water, around sand, and recognize you're going to need more sunscreen. And to look at the UV index, I love the weather app actually. And the EPA, so the Environmental Protection Agency, has a lot of information about UV indices. And actually, I'm going to go to this slide. This is the EPA's guideline and recommendation on sunscreen and UV. So they said that if the UV index is low, less than 2, so that's like January, December in Seattle, it's pretty low. You can be outside, wear just light sunscreen. And again, in winter, you still need sunscreen because of the snow. So, and anytime it's 3 or above. On Seattle, we get up to the 7, sometimes 8 in the summer. So there's this misunderstanding that cloud cover protects us, and it does not. So check your UV index, see where you're at. All right, my other favorite question, what is the best sunscreen? There is no best sunscreen. The best sunscreen is the one that you like, you aware, what works for you does not work for somebody else. I like the ones that the physical blockers, I don't buy it. There's no particular brand that's better than another. But just look for broad spectrum, SPF 30, and water resistance. and this is my last slide here. You know, it is really, really difficult to have had skin cancer, a melanoma, a family member, a friend with it. And so what can we do going forward other than, just protecting ourselves? It is really stressful and we all recognize that. And I just, saying that out loud is really important. But there are things you can do. So the one thing is getting to know your skin. Monitor, get a mirror, perform an exam. I say, look at your skin once a month. If you look at it more than that, you won't notice changes. Get a friend, get a family member, take photos and refer back. And the AAD has sort of some recommendations on how we look at our skin. And all the sun-safe practices we talked about today, sunscreen, shade, all of those things are really important. And of course, to see your local friendly dermatology provider. We are all happy to be part of your team and your cheerleader. So, and with that, here are just some references. All of these places have really great information. And yeah, with that, I'd like to thank you all for being here.
Thank you very much. I'm going to suggest that for those that need a break, we take a break. And if Dr. Cogen and Dr. Lee maybe offer to stay near the front, for those who want to ask questions during the break, maybe feel free to come up and ask them then. Thank you. 10-minute breaks. We'll be back at
Let's do a check of temperature. The room was too warm for many people before we started. We've made some adjustments. Is this okay for the vast majority? We're not freezing anybody, but we're not frying anybody. Okay, maybe we got a balance. That's great. I will tell you that at last count, I saw 77 people on the virtual. So they're about equal numbers in both places, a great attendance here. Okay, let's go ahead and get to, we have two exciting talks before lunch. Let's start with Dr. Lisa Tachiki, who joined us after her fellowship here. We were delighted. She's an assistant professor in hematology and oncology at the Fred Hutch and the University of Washington. And her topic is a timely one because as these drugs came in, the studies don't quite know how long they should happen, what kind of dosing happens. Those are critical when you're on these meds, as you know. Do you need to be on them longer? Do you need to be on them shorter? Incredibly important topic that she's going to try to cover in a way that hopefully we'll all understand. Thank you, Dr. Tachiki.
Thank you, Dr. Byrd, and thank you guys so much for having me here today. Oh. Please hold. Perfect. Okay, this looks more familiar. I'm just going to get the laser pointer up so that way I can point things out as we go through here. So this is kind of an outline of what I would like to talk about today. First, I'd like to summarize the dilemma that we face when we treat our patients who are responding well to immunotherapy. A good dilemma, but a dilemma nonetheless. And then talk about one way that we've addressed that with this regimen called reduced frequency dosing. And then kind of talk about the impact of something like reduced frequency dosing. So as a baseline, and it was great that Dr. Lee gave a great primer on Immunology 101 there. The idea here is that immunotherapy refers to a class of drugs that boost the body's own immune system to fight and kill off tumor cells. In particular, she referenced a class of drugs called immune checkpoint inhibitors. And those drugs, which include nivolumab and pembrolizumab, have dramatically improved outcomes for many patients with cancer. So the concept behind immune checkpoint inhibitors is that tumor cells, represented by this purple cell here, learn how to actually connect to or communicate with the immune system and actually shut the immune system, in particular these T cells, off. And they do so by a signaling pathway called the PD-1 receptor. And so what the cancer drugs do, both nivolumab and pembrolizumab, is they actually sit and block that PD-1 receptor. So that way, when a tumor cell tries to attack the immune system or to silence the immune system, it's not able to actually make that connection, which then allows the immune system to stay invigorated, recognize the cancer, and kill it off. Because of the fact that these drugs have had significant benefit in our patients, meaning advanced melanoma or metastatic melanoma patients used to live on the span or average of 8 months, now is extended to beyond 5 years. We've had some incredible outcomes, but then the question becomes, what do we do in these patients who are long-term benefiters and survivors of these immunotherapy drugs? So really, how long to continue these treatments is essentially unknown. One option is that we can continue immunotherapy essentially indefinitely, as long as a patient continues to benefit from it. However, logistically, that's asking a lot of our patients because these drugs are dosed every 2 to 3 weeks in clinic. Financially, that's also not a viable option. These drugs are very expensive. So the combination of ipilimumab and nivolumab, which many of our melanoma patients get, the drug cost alone is almost $300,000 for 1 year for one patient. Similarly, pembrolizumab or Keytruda for 1 year for one patient is almost $200,000 in the drug cost alone to the healthcare system. So the other option has been to arbitrarily stop immunotherapy at a designated time point. And usually that time point has been 2 years based on the fact that some of the big clinical trials that studied these drugs used a threshold of a 2-year mark. However, there are certain patients, in particular, those who don't achieve a complete response, meaning those who don't fully respond to immunotherapy on these scans, might actually have their cancer return if we stop immunotherapy too early. So based on that observation, that tells us that there are some cohort of patients who might have some biologic benefit to having immunotherapy continued, which means that some patients might need a longer duration of immunotherapy. However, like we said, logistically, that's a pretty challenging ask because logistically and financially, that's not viable. And so what we have done in our clinic as the kind of middle path approach to address this issue is something called reduced frequency dosing, which refers to the idea of giving a dose of nivolumab or pembrolizumab once every 3 months. And the way that we do that is we start patients on standard treatment and then offer reduced frequency after their cancer has started to respond to standard doses of treatment. So kind of graphically, how this looks is a patient with metastatic or advanced melanoma will come into clinic and we'll start them on standard doses of treatment. Oftentimes, those doses are once every 2 or every 3 weeks. We'll continue to get scans on these patients, and as their scans show that their cancer is responding or shrinking, we then will have discussions with our patients about how long to keep them on treatment. And again, those options include staying on the same regimen for as long as it's working, which could be indefinitely, stopping at that 2-year time point, or this middle path approach where we use reduced frequency dosing. So how did we come up with this every 3-month interval? It really comes from the fact that the phase 1 studies, so the early studies that looked at nivolumab, actually evaluated how long these drugs continue to interact with the immune system. So what I mean by that is this is a really busy graph here, but this is a figure from the phase 1 study that looked at and evaluated nivolumab. And what they're measuring, especially on the left panel, the blue curves here, what they're actually measuring is how much of that drug continues to bind with the immune system over time. So the same graphic that I described earlier, that interaction between the drug, which is the bright green dot, and the PD-1 receptor is what they're measuring. And what you can see is after a single infusion, that PD-1 receptor occupancy remains sustained for 60 days, in this case up to 80 days, and on this upper right graph, up to actually 100 days after a single dose. So that's kind of the rationale for how we came up with the every 3-month interval. And so my mentor, Dr. Shlinder Bhatia, who some of you may know, actually started this practice almost a decade ago. And what we did was we collected the outcomes or the experience of these early patients who adopted reduced frequency and were able to report what that looked like. Fortunately, we were able to present this at ASCO, which is a big international meeting that happens annually, and we received an award for our work here. So these are really busy graphs, but what I want to tell you is that these are called Kaplan-Meier curves. And what they represent is over time, how many of our patients continue to live well without their cancer growing or progressing. So to draw your attention to the curve on the right, this is a Kaplan-Meier curve looking at patients who participated in one of the big clinical trials that got nivolumab approved. And in particular, what we're looking at is over time, how many patients continue to be alive without their cancer growing? And we stratify these groups of cancer patients based on the extent or depth to which their cancer responded to immunotherapy. So CR represents complete responders, or those who had their cancer completely go away or not visible by imaging from immunotherapy. Similarly, partial responders, PR, are people who had their cancer partially respond to immunotherapy. And stable disease represents cancer patients who did not have their cancer grow, but we didn't really see shrinkage at the time that they were receiving treatment. And what you can see is that over time, on the span of years, these patients overall continue to do very well, but naturally some of these patients may stop responding to treatment and have their cancer grow. So this represents what happens to patients in a big historical trial who receive standard therapy at the standard doses every 2 to 3 weeks in this trial. In comparison, on the left, we're looking at the outcomes of the 23 patients in our cohort who received reduced frequency dosing. And what I want you to kind of see is that overall the pattern of response appears comparable to what these historical outcomes look like. So we think that we may not be compromising patient outcomes by using reduced frequency dosing. The second question that comes up is, well, if we're using less drug, can we actually spare patients from side effects? Interestingly, when we use reduced frequency dosing, the side effect profile is comparable to as if patients were receiving treatment every 2 to 4 weeks. So within our group, what we in particular are looking for are these severe autoimmune side effects. If we're boosting the body's immune system to fight off cancer, what we're looking at is the possibility that the immune system can unfortunately attack the body itself. And when those side effects are severe, we can quantify them. So within the cohort of 23 patients that we're talking about, there was a 28% rate of these severe side effects. In comparison, if we look at these thousands of patients who've received these drugs on clinical trials, that rate is about 20%. So pretty comparable. The last thing we looked at was, can we actually save money and time by using reduced frequency dosing? So as you might have noticed, I'm talking about 15 patients here. So we had a 23 patient cohort, but 15 of those patients actually received treatment for much longer than 2 years, which is kind of that arbitrary time point in which we think about stopping immunotherapy. So we evaluated the total cost and time spent for those patients on reduced frequency dosing who on average were on treatment for 3.5 years. And we compared that to the costs incurred from using treatment for 2 standard years. And we found that despite that extended duration, we still save money, 1.1 million in drug costs for 15 patients and 384 hours of clinic time saved. Another way to think of this is if we actually create a theoretical model where our patients get 6 months of standard doses of immunotherapy, and then after doing well, we transition them to reduced frequency dosing, the same amount of drug that you use in 2 years standardly can end up extending the duration of treatment, 84 months with pembrolizumab or 114 months with nivolumab. So why is this something that we potentially want to look into, or why am I even talking about this? Well, the helpful thing with these drugs is that they're highly effective, not just in melanoma, but in over 20 different cancer types. And so there are many patients who actually benefit from immunotherapy. And the list on the left here represents a number of the different tumor types that actually use immune checkpoint inhibitors. And what we also know is that nivolumab and pembrolizumab are 2 of the highest grossing drugs in the world. And that's because they're effective and they work for a lot of patients. So if we were to apply something like reduced frequency dosing to these drugs, we actually could potentially save on the span of billions of dollars. So with nivolumab, if we use reduced frequency dosing, you can actually save $7 billion in just 1 year alone. Pembrolizumab, there is a decimal point error, so that is my mistake. It should be 1.59 billion that could have potentially been saved. So 8.2 and 2.1, it was the expenditure of these drugs in 1 year alone. So taking it another step further, we know that our patients, at least from looking at their outcomes, big picture wise, they tend to do well. What's actually happening in the blood of these patients who are on reduced frequency dosing? Can we characterize that interaction between the immune system and these drugs? And what we've been able to do is with the funding from CUNY grant, which I was fortunate to receive, we were able to collect long-term data on 31 patients who have since been put on reduced frequency dosing at a total of 260 time points. And by doing so, we can evaluate kind of how the drug and the immune system to continue to interact. So I want to say a huge thank you to our patient participants who gave both their blood and their time in order to make this work possible. And what we found is similar to what we would have anticipated based on the phase 1 data. So what I'm representing here is a similar graph to that kind of initial graph that I showed from the phase 1 results. What we're saying is that this is a patient who received nivolumab every 12 weeks. At time 0, they got an infusion, which is represented by this black arrow here. And what we're measuring over time with this blue curve is that the immune system continues to have interaction with this drug throughout the 12 weeks that this patient continues to kind of be followed. Meaning in between the time of their doses every 3 months, we're still seeing that interaction of the drug with the PD-1 receptor. This orange curve actually represents serum drug concentration. So how much free drug is floating around in a patient's body. And what we also know is that in order to have an effective dose, we need to maintain above this minimum effective concentration. This was a number that was calculated by the NCI based on kind of data on which sort of concentrations of the drug are needed for good effect. And what we see is that in between that time of the drug dose, even beyond 12 weeks, the serum drug concentration remains well above that kind of minimum effective dose. So based on this information, we know that patients may potentially experience disease control and even side effects from reduced frequency dosing. But in order to implement this in a larger group, we need to kind of validate this finding in a larger clinical trial setting. This also means that based on the kind of pharmacokinetic and pharmacodynamic data that we have, that precise dosing every 2 to 4 weeks might not be necessary to generate anti-cancer effect. And taking that a step further, it's possible that current dosing regimens may actually be giving treatment more frequently than is potentially necessary. So reduced frequency dosing may be a way to save both time and money. I think another important takeaway for our patients here is that because we see the fact that these drugs last so long in the system, that means side effects can still happen long after stopping therapy, even up to we've seen a year out. So something that's important to be vigilant about. So where do we stand now? Fortunately, like I said, we were able to share our work at a big international conference, and we're also able to publish this data in a journal that focuses on immunotherapy. So the next piece has been using that sort of correlative data that was provided generously by our patients to make sure that this dosing regimen looks safe from evaluating the immune system and drug interaction. And since we've done that, the plan now is to create a larger clinical trial to evaluate this dosing regimen in a bigger cohort of patients. And the implications for this are huge. Especially this group here from the Pacific Northwest knows the amount of travel to get from, for example, South Lake Union to, let's say, somewhere like Bellingham can be quite intensive. And so if we are able to safely deliver immunotherapy at a much less frequent interval, that would be quite convenient for many of our patients who have barriers to accessing healthcare. Similarly, internationally, most patients don't have access to immunotherapy. So in low and middle income countries, these are the percentages of people who have access to immunotherapy. And so with that in mind, we are also conducting a phase 2 study in Uganda, which is a institution that we already have a well-established partnership with. And what we are doing is using a sort of reduced frequency dosing approach in order to bring immunotherapy to Uganda. And by doing so, we can markedly reduce the cost of immunotherapy drugs by almost 100-fold. And if this is successful, this would be something that could potentially be immediately implementable in some of these countries who don't have access to immunotherapy at all. And I just learned 2 days ago that we actually did receive funding to perform this clinical trial, thanks to a grant by the CUNY Foundation. So you'll definitely be hearing more to come from this project. And so with that, I want to say thank you to everyone who's helped kind of with the data that we've collected so far. First and foremost, I want to thank the patients who played a huge part in being able to collect this information, both outcomes wise and looking at the correlative blood work. I'd like to also thank the rest of our research group and the team who's put on the conference today. And with that, I'll take questions.
All right, we have time for a couple minutes of questions from down here. We'll start here and then we'll have one from the online as well. Go ahead.
I want to thank you. I want to thank you for pointing out side effects. My husband was on nivolumab for 2 years, and a couple months after treatment, psoriasis hit severely. And then 4 months after treatment, he was stricken with autoimmune limbic encephalitis, which we're told is rare, but it happens. So being vigilant is very important. And then it metastasized again terminally, and he died last March. But everybody's awesome here. But thank you for bringing it up. It's so important to be vigilant about side effects. It's a wonderful drug, but just be vigilant. But thank you.
Thank you. Thank you for pointing that out. That's a real life example of how the fact that these drugs are actually sticking around in our system for a very long time. And these side effects are things that we're trying to still learn, who are the ones who are going to develop these really severe bad side effects. So that's all part of the research that I'm working on as well.
Lisa, we got a question from our virtual audience. What has been the response to the manufacturers of Keytruda and Opdivo to the reduced dosing? And be as honest as you are comfortable being.
Actually, I would say, I'm not necessarily going to be getting funding from any of those individuals to perform work like this, but I do think they're open to the idea that there's definitely more to be discovered with kind of how the immunokinetics of these drugs work. As far as potentially getting assistance from them, I would say I think they're supportive, but aren't necessarily hands-on involved in that research.
Thank you. I had a question as well. I think the benefit of the every 3 months versus every 3 weeks is huge for patients. I was a little disappointed to see that the side effects are the same. Do you have an explanation for why that might be? And is there a way to potentially reduce toxicity with reduced frequency?
Yeah, that's a fantastic question, Dr. Byrd. Let me see if I can go back to the very beginning here. But what I actually want to point out is that something I didn't talk about is the fact that this PD-1 receptor occupancy, which we're seeing on these panels on the left here, represent different doses of immunotherapy. So this is given at 0.3 milligrams per kilogram. Nivolumab is given at 240 milligrams. So this would be like giving a 20 milligram dose of nivolumab. And what we're seeing is that at these different doses, we still see that persistent PD-1 receptor occupancy, which tells us that it doesn't take much. These drugs are so incredible at finding their target. It doesn't take much to actually activate the immune system. And what you can actually see are these yellow curves here. And at these yellow curves, you can see that the serum concentration, the amount of free drug floating around in the blood, varies despite the fact that that receptor occupancy kind of plateaus throughout. And so the concept is that it's possible that maybe lower doses of this drug might lead to faster clearance of drug concentration without necessarily having an effect on that immune engagement. So instead of actually using doses like 240 milligrams, what if we actually use doses like this? especially in patients who are actually getting or have a high risk of side effects? Can we actually spare them from that duration of toxicity because the drug kind of lasts around in the blood much shorter? So that's kind of the next step of what I'm doing with my research, and then hopefully more to come with that. But that's the current hypothesis. Thank you.
Maybe ask her in the next break. You got us back on time, Dr. Tachiki. Thank you. It's a pleasure to introduce the next speaker, who is our keynote speaker. Dr. Dave So is our speaker coming from Houston. Got here about 2 o'clock this morning because he's a busy clinician and as a surgical oncology fellow at MD Anderson Cancer Center. I know Dr. So well. He has quite a pedigree. He went to Harvard University for undergrad, went to University of Michigan for medical school, came to us at University of Washington for his general surgery training, and now is finishing a fellowship at the MD Anderson Cancer Center. We came close to hiring him, but he's got an clinical interest, a little separate from the melanoma practice that I wanted to have you do. The good news is he's going to be at the prestigious Medical College of Wisconsin. Probably the cheese offering that they gave him was higher than we could offer. But we're delighted to have him coming. He's in the lab of Dr. Jennifer Wargo, W-A-R-G-O, and you might want to look up her work online. And he's going to bring some of that information today. And I love the title of his talk, of Gut Check. So please welcome Dave So.
Thank you very much for the very kind introduction from Dr. Byrd. Again, I'm Dave So. I'm currently a fellow in surgical oncology in Houston at MD Anderson Cancer Center, and it really is truly a privilege to speak to you today on some of the research that I've been involved in over the last 2 years. Now, sometimes when I get opportunities to speak to like a large group like this with shared interests, I often sort of wonder like, how did I get here? And to be honest, the series of fortunate events that led me to speak to you guys today started, like Dr. Byrd said, by starting general surgery residency here at University of Washington in Seattle in 2014. And then, but by the time I showed up here, I long had a sort of deep interest in cancer and cancer treatment. So I knew that I wanted to follow in Dr. Byrd's footsteps and sort of go into surgical oncology. But I also met a couple of research mentors, Dr. Plarsetti, who was a pancreas surgeon by trade, and Dr. Seth Pollack, who was actually here in one of the labs in Fred Hutch. At the time, he was one of the sarcoma medical oncologists. So I spent number of nights in this very building, listening to talks, but mostly in the basement, doing analysis and flow and all that kind of stuff. But it sort of, they were both deeply interested in tumor immunology and sort of how best to leverage the ever-expanding field of immunotherapy and immunotherapeutics to treat their diseases. And sort of many of those lessons and understanding about how tumor biology changes with immunotherapy is sort of universal and goes across many disease sites. And so when I went to MD Anderson for fellowship, I knew that I wanted to pursue this kind of career in academic medicine and specifically translational research in tumor immunology. And that's where I met Dr. Jen Wargo, who is a world-renowned melanoma surgeon, first and foremost, but also one of the leading experts in the field of microbiome research, particularly as it pertains to cancer immunotherapy and tumor biology. So today I'm going to sort of try my best to give a little bit of a context of where the microbiome research field has come from, and perhaps more importantly, where the future lies, specifically melanoma in the world of treating patients with immunotherapy. I'm also keenly aware that I'm the only thing that's standing between you and lunch, so I'll try to keep things brief. So we'll break this down into 3 main components. First, I'll give a little bit of background about the microbiome as it pertains to immune response against melanoma. And then I'll highlight some of the seminal work that our lab and others have done to measure and sort of elucidate the undeniable impact of the gut microbiome on immunotherapy response. And finally, I'll highlight one of the projects that I've been personally involved in recently as more of a showcase of sort of where the field is headed and how we're going to take the lessons that we've learned so far to actually meaningfully improve patients' lives and outcomes. Now, it's not an exaggeration to say that the advent of immunotherapy has truly revolutionized how we think about cancer therapy across all disease types. The American Association for Cancer Research puts out this sort of cancer progress report every year, and in it they highlight sort of the pillars of cancer therapy as it exists today. And of course, no doubt, immunotherapy has become one of the mainstays of treatment, even in the first line and localized setting. And at the forefront of the explosion of the field of immunotherapy, there's always been seminal studies within melanoma that sort of have led this charge. And in 1994, Dr. Steve Rosenberg published a study using IL-2 to treat patients with metastatic melanoma. And of course, some of the first studies to demonstrate efficacy of things like ipilimumab or immune checkpoint blockade came in the setting of treating melanoma. And then over the last 2 decades, we've learned a lot about some of the hallmarks of response and also, importantly, toxicity to immune checkpoint blockade. And as our understanding grows, the complexity involved with both factors that are sort of intrinsic to the patient within the host and factors that are external to the patient have sort of grown concurrently. And one of these factors that clearly play a role in patients' response to tumor involves the microbiome. Now, when it comes to the microbiome, this is sort of a tremendously broad word that encapsulates both the extrinsic and intrinsic factors. And there are, of course, well-known microbes like HPV that drive pathogenesis of certain types of cervical cancers and squamous cell carcinoma and things like that. But today we'll mostly focus my talk on the gut microbiome, namely the sort of the bacteria that colonize and reside in your digestive tract. And this microbiome that resides in all of us have been the subject of intense investigation over the last few decades. And we currently estimate that there are about 10 times more tumor cells than that reside within our gut compared to like our own cells. Some people estimate that there are about 100 trillion bacteria, representing about 2 kilograms in actual weight that reside in our gut and our skin. So in many ways, to think that the gut microbiome has no impact on tumor immunity and immunotherapy response, maybe that would be the sort of harder thing to believe. And the concept of utilizing bacteria against tumors is certainly not new. Somewhat famously, there's a orthopedic surgeon in New York at the Hospital for Special Surgery by the name of Dr. William Coley. Many people sort of cite him as one of the sort of first recorded uses of actual immunotherapy in patients. And this is back in 1908, this New York Times article. He noticed that he was treating patients with recurrent sort of soft tissue and bone sarcomas and tumors. And he found that in a couple of patients who had developed fevers due to a streptococcal infection, that's a bug that's commonly resides on our skin, that these patients somehow experience remission in their tumors without doing anything surgically to them. And so he had the idea of sort of concocting a potion of sorts of streptococcal bacteria and injecting it into the tumor of a patient, a 35-year-old Italian gentleman who had had 2 resections already and already had a recurrence and had basically weeks to live. He injected this over a period of 8 weeks, and 8 years later, the patient was still alive, and the tumor basically disappeared. And he later developed this sort of toxin mixture, and he called it Coley's toxin. And many people cite that as sort of the first, certainly the first intratumoral immunotherapy. So as our ability to sort of characterize and sequence the genomes of these countless bacteria that live in our gut and our body, there have been new efforts to sort of sequence all of the known, basically, bacteria associated with human tissue. And this, in combination with all the sort of next generation sequencing that's available and all the sort of computational algorithms that I won't get into, mostly because I don't understand them still, it basically allows us to have a very sort of high throughput way of understanding not only what types of bacteria that exist, but specifically what kind of species and even what kind of strains of bacteria that exist. And also importantly, what the sort of overall global makeup of that community is and the relative abundance of each of these taxa. Now, before I get into this, I'll never forget a conversation I had with my father-in-law, who is a psychiatrist by training. He's very smart and very curious person. And I was telling him about how excited I was to go into the lab and start sort of working on the things in Dr. Orgo's lab. And I was explaining to him some of the things that I'd heard and sort of read about, like the microbiome in your gut can really impact immunotherapy response. And his classic response was, well, you mean to tell me that a skin cancer can react to what's in your poop, the bacteria that's in your poop, using immunotherapy? How does that work? And at the time, I didn't really know. So I just said, well, it does. And he looked at me like, okay, we'll see what happens. But what I've come to realize over the last 2 years and sort of being involved heavily in the lab and studying this as much as I could, is that within the field of the tumor biology and tumor immunology, the answer is getting much more complicated. But in general, our immune system has sort of a series of mechanisms. One of them is called the innate immunity, and that's sort of the first line of defense. That's evolved over millennia and millions of years. And it's basically a quick and robust way for the immune cells to respond to a pathogen. And this reacts to certain conserved and sort of common antigens that are present across many different types of bacteria and pathogens that we normally see. And so it allows our immune system to, without sort of waiting for the typical sort of antibody, antigen-specific mediated response, which takes some time, it mounts up and ramps up the response, and then secondarily recruits more agents to continue to sort of undergo adaptive immunity. And this is probably what underlies the some of the effects that Coley's toxin, for instance, had, is some of those conserved sort of conserved elements of the streptococcal sort of mixture was being recognized by our body's innate immune system within the tumor microenvironment because he was injecting it into the tumor. And that mounted a robust immune response, recruited all those immune cells, and then the immune components of the adaptive response can then look at specific cancer-associated antigens and try to make antibodies and make T cells against those specific types. The positive reason for why the gut microbiome affects our systemic immunity lies in part in the interaction between the immune cells and the immune system. There's a very robust immune system that resides just under the lining of our gut, which kind of makes sense. We need to sort of develop immunity and be able to sort of tolerate a lot of things that we eat and interact with. But there are also other proposed mechanisms for how the microbes sort of affect the adaptive immune response systemically by using sort of key modulators and metabolites. And all that is to say, while there's really no concise answer I could give my father-in-law today about why or how this works, I can tell him that there are many, many hows at play here. And just a quick side note, the idea behind Coley's toxin from 1908 is still very much in play in 2024. This is actually work I did here at Fort Hutch with Seth Pollack and sarcoma, where we were injecting TLR4 agonists. And TLR4 agonists, it was a sort of a powerful activator of the innate immune system that I talked about, designed to mimic lipopolysaccharide. It's like a common element found in the cell walls of gram-negative bacteria. And so we were injecting these into patients with metastatic sarcoma, and we were injecting them directly into the tumor. And we were seeing very durable responses within the injected tumors and also some systemic effects among the T cell components, both within the tumor, but also in the circulation. So it's a little bit of a sidebar, but I just wanted to sort of, it was kind of a full circle moment to be presenting this back to an audience in this auditorium. So with that context in mind, I'd like to share some of the sort of seminal work that Wargo Lab and other leaders in the field have done to understand how the gut microbiome can impact patients with melanoma, and specifically as it pertains to immunotherapy response. So I'm going to sort of go through a series of seminal papers and kind of highlight the top line conclusions and sort of what questions they were asking and what we learned from them. One of the first and earliest studies came out of Tom Gajewski's group in 2015, and they were interested in sort of trying to elucidate the importance of the gut microbiome and its makeup when it comes to immunotherapy response in cancer. So they elegantly used 2 different strains of mice. These mice are genetically a little bit different, but also importantly reared in a different sort of environment. And they were known, these TAC and JACs, as you see up there, they were known to have distinct different microbiome, gut microbiome profiles. And when implanted with melanoma cells, you can see that this is a tumor growth curve. Basically, the longer that the line stays flat like this, the less the tumor grows. So the better sort of the immune system is at sort of regulating and down and protecting the mouse against the tumor growth. The mice in the below here, the JAX mice, they were naturally just better at dealing with these melanoma cell lines, and the tumors did not really grow. These TAC mice, these tumors grew like wildfire. But you look at this line right here, this is TAC plus JAX feces. That's a little bit of a nauseating story, but basically what they were doing was they were using the poop from the JAX mice, the mice that were able to control melanoma, and they were feeding it to these TAC mice. And what they found was that when they did that, these mice looked just like the JAX mice. So that sort of suggested that the microbiome, what resides in the gut microbiome of these mice was underlying the mechanism for response or better immune surveillance of the tumor versus not. And they highlighted some of the sort of taxa or specific bacteria and families that were associated with better response or better control of tumor compared to those that sort of outgrew them. Now, that was without any sort of immunotherapy or any kind of treatment. A paper published in the same exact same issue, Lawrence Zipvogel and their group demonstrated now the impact of the gut microbiome, but this time in the setting of anti-CTLA-4 therapy. So again, in this, they did similar experiments with a slightly different tumor cell line, but when they implanted these tumor cell lines in mice, they found that treating the mice with the anti-CTLA-4 therapy, so basically ipilimumab, decreased their ability to grow, which makes sense. Now, this is in sort of like normal mice. When they took this to the germ-free mice, these are mice that are specially grown in sterile conditions where basically their gut is totally sterile. Basically, they have no gut microbiome whatsoever to speak of. The anti-CTLA-4 on the same tumor cell line had no impact. And a graph I'm not showing here, they also treated the regular SPF mice with antibiotics and then gave them anti-CTLA-4, and that also did not have a response. Subsequently, our lab took some of these questions into the clinical realm. Now we're looking at patient samples. So we characterized the gut microbiome profiles of 112 patients. These are patients who had already been treated with anti-PD-1 therapy for advanced melanoma. And these were all patients at MD Anderson. And not surprisingly, there are people who responded and there are people who didn't. And this is all sort of retrospective, meaning that we're just looking back at the microbiome profiles of the people who did respond and who did not. But when we analyze the gut microbiomes of the responders versus non-responders, the patients who responded to immunotherapy had what's called higher alpha diversity. That's just sort of a general term to describe the diversity of bacteria that are present within the gut microbiome. And you can see that in the progression-free survival that Dr. Tachiki explained so beautifully just now. Basically, the people with the high diversity, high alpha diversity did much better in terms of prolonging their duration until they progressed. Now, furthermore, careful profiling of these patients' gut microbiomes revealed that certain bacteria, such as those in the Ruminococcaceae family, for instance, and we'll come back to why that's important later, seem to be very strongly correlated with response, meaning that if patients had a relatively high abundance of rumino before their treatment, these patients were more likely to respond to immunotherapy. Now, work done by others since then have profiled many patients across many different cohorts across the world. And these two studies published in Nature Medicine corroborated some of the findings that we found in terms of the microbiome signatures associated with both response to immunotherapy and also associated with toxicity to immunotherapy. That's something I'm not going to have time to sort of delve into, but that is the other sort of big piece of the microbiome puzzle is how your gut microbiome modulates not only response, but your toxicity, such as immune-mediated colitis and encephalitis. Now, one thing that I didn't mention that I'm sure a lot of people are thinking about is, well, what about what you eat? You know, we are talking about the gut microbiome having a huge impact on immunotherapy response, but it wouldn't be surprising to know that the kind of diet that you eat or the types of food that you ingest can and do impact your gut microbiome. So Chris Spencer and others in our lab then sort of tackled that next bucket of questions. Now, prior work had sort of highlighted the importance of dietary fiber as a potent modulator of your gut microbiome. That sort of makes sense, as where a lot of the natural sort of colonizers of our gut microbiome depend on undigested fiber as fuel, and the fiber provides a substrate for fermentation, which can subsequently impact and affect the metabolomic profile and composition of the gut microbiome. So it made a lot of sense. So first, again, we went back to our patients. To answer this question, we looked at 128 patients for whom who were treated with anti-PD-1 therapy in the setting of advanced melanoma, for whom we had both the gut microbiome profile, like we've shown before, and also we had some sort of dietary data. And we were looking and surveying people for an estimated dietary fiber intake per day. And those who had sufficient or over 20 grams of dietary fiber per day, when you looked at their progression-free survival, they tended to do better after immunotherapy than patients who had insufficient fiber. We then took this back to the preclinical model to sort of test an experiment in the mouse model. Does this recapitulate within the setting? So again, in a similar sort of experiment setup, the mice were injected with melanoma cells and the tumors were grown, and the mice were given either high fiber diet or low fiber diet. And they were either treated with nothing or basically a placebo or anti-PD-1. And what I want to point out here is that the tumor curve that's the lowest here, those are the mice that were treated with a high fiber diet and got anti-PD-1. So that did a really good job at killing the tumor. But if you look at the low fiber group, even the mice that got the anti-PD-1 therapy, their tumor grew. So this is, again, just a flavor to suggest that the dietary intake and specifically the amount of dietary fiber may have a big impact, almost certainly mediated by the gut microbiome on immunotherapy response. Now, another thing that we looked at was probiotic use. This is something that's quite common these days, and we were able to survey a similar cohort of patients on whether they took any kind of probiotics or not, and that's on the left here. We did not see any sort of significant difference in terms of their progression-free survival in the patients. And actually, when we looked at doing that kind of same mouse experiment and treating all those tumor-bearing mice with anti-PD-1 therapy, the mice that got these sort of commonly available, the bifido or the lactobacillus-based probiotics, they actually did worse. The mice actually grew tumors faster. And this was a little bit of a surprising finding, but it sort of highlights the fact that the diet certainly plays a role in sort of mediating immunotherapy response via the microbiome. But that very, very careful work needs to be done to sort of figure out what kinds of food are actually helpful. We have a talk coming up after lunch that it will get a little bit more into the specifics of that, so I won't go into too much detail. I was just mostly surprised at how much you have to actually eat to get even 20 grams of fiber in your diet. It's a lot of beans. So I think, I and a lot of young people also, especially these days, I think we grossly underestimate the amount of fiber we think that we take in. And to that end, using diet as a precision instrument to intervene and sort of modulate immunotherapy response is something that's being looked at very, very carefully and rigorously by some of the people at MD Anderson. Carrie Daniel and Jen McQuaid, along with Ashley Holder and Dr. Wargo, are looking into a big clinical trial and projects that sort of take into consideration as the intervention, the actual diet, not only as it pertains to the fiber, but other sort of macronutrients, and whether that can modulate immunotherapy response in a way that even could potentially outperform some of the other sort of pharmacotherapeutics and combination therapies even. So this is sort of work that's being done in the field. So I want to take the remaining time to sort of talk a little bit about some of the future sort of directions of microbiome research as it pertains to tumor immunotherapy. And I'll sort of go a little bit more into the weeds on one of the sort of more recent projects that I've been involved in. Ever since sort of the first papers came out describing the potential impact of the gut microbiome on immunotherapy response, obviously we and others have been trying to figure out how to use that information to actually meaningfully improve response in patients with melanoma getting immunotherapy. And one of the ways that we have found to sort of be a modulator of the microbiome is something called fecal microbiota transplant, or FMT, fecal transplant. Now, another slightly nauseating anecdote. There are written accounts dating back as far as the 4th century BC in China, where physicians were prescribing what they called yellow soup. I don't need to go into detail about what that means, but essentially they were taking stool from healthy donors, people who were not experiencing any sort of ailments, and then they were giving it to people who were basically on death's door, dying of horrible diarrhea. And they wrote that they were able to rescue some of these people from the brink of death by giving them this yellow soup. So Within the space of the gut microbiome and immunotherapy response, Erez Baruch and our lab and some collaborators first utilized FMT as a way to introduce what we deem to be sort of like the optimal microbiome for immunotherapy response in melanoma patients. So in this study that was published in Science in 2021, they took 10 patients with advanced melanoma who are already resistant to anti-PD-1 immune checkpoint blockade. So their disease basically grew despite PD-1 therapy. Then they utilized the stool from 2 donors. These are patients, the donors were patients who had melanoma, who had experienced complete response to immunotherapy, to anti-PD-1 blockade. So these patients were deemed to be sort of like the optimal stool microbiome. So the 10 patients got the FMT of this donor stool, and then they were re-challenged again with the anti-PD-1 therapy, the things that they did not respond to before. And while this may not look super impressive, these are patients who had already failed anti-PD-1 therapy. 3 of these patients responded to immunotherapy after getting their FMT. And when we looked at their tumors before and after FMT and treatment, before, even though they had already received anti-PD-1 therapy, their tumors were really devoid of the brown dots or the CD8 T cells. Those are the kind of effector T cells that do the tumor killing. And afterwards, they saw a huge influx and infiltration of CD8 T cells. So all this is to suggest that potentially the FMT was one viable way of delivering that sort of ideal microbiome into the gut of patients who were previously refractory to turn them into responders. Another similar studies published again by the VAR's group and Hassan Zawar's group demonstrated similar results in 15 patients who had not responded, again, to checkpoint blockade, and this time using sort of pooled samples from 7 separate donors. Again, these are patients who had already responded or had a really good response to immune checkpoint blockade. These 15 patients then underwent FMT, and they were treated with the same anti-PD-1 therapy again. And the 6 patients here, seen in blue, had either sort of stable disease or control of disease, or sometimes had really a good response. Their analysis also included more specifically the gut microbiome profiling of the 6 patients who did respond. And when we looked at their microbiome before and after FMT in these responders specifically, again, some of the same sort of bugs popped up. Things like Ruminococcacea here in green, those were increased or enhanced in terms of their abundance in the patients after FMT, in the patients that did respond. And this was associated with some sort of signatures, immune signatures that were associated with favorable response to immunotherapy as well. Now, while these were very exciting results, because for the first time we were actually able to translate some of the sort of findings in our mouse models and our retrospective data into the prospective realm, into the clinic, and actually treating patients with FMT. But as you can imagine, FMT comes with a fair number of drawbacks. The cost and infrastructure associated with stool collection, processing, delivery, they're substantial and not maybe unlike something like TIL therapy. It requires a lot of setup. And it's certainly not the most scalable product. But also from a conceptual perspective, we still don't really know what constitutes the perfect stool donor. We have been using patients who have previously responded or had complete response to immunotherapy, and we presume that that is sort of the optimal donor. But we don't know what components of that sort of stool microbiome is contributing the most. And also, if you think about it, these donors, they're people. They're just walking around. So they have to come in and volunteer their time and donate their stool. And if they move away, or if they are no longer willing to do that, then you lose your sort of stream of donors, the product. And finally, unlike the sort of specific medications that have generally sort of predictable, measurable responses, like Dr. Tachiki showed with her data with immune checkpoint blockade, the effect and impact of FMT, especially as it pertains to engraftment, or how much of the bugs that you actually give actually take into the patients, that's something that's extraordinarily difficult and challenging to study, mostly because we share a lot of the microbiome with everyone else. There are really common bugs that are in sort of slightly different potential abundances in each of us and make up a slightly different composition. But to be able to track one person's Ruminococcacea to another person's Ruminococcacea has been a challenge. So in this context, I want to talk to you a little briefly about a recent study that we published within this sort of space, mostly just to highlight some of the work that's been going on at the sort of forefront of this field. So going back to the ruminococcaceae idea, we wanted to see if there was a way to deliver ruminococcaceae specifically without having to resort to the FMT methods. And in this context, we partnered with Sirius Therapeutics. This is a microbiome modulation company. They basically make sort of microbiome pills. And they're the first company to have an FDA-approved product for as a microbiome modulation therapy. Notably, they use theirs in the treatment of refractory Clostridium difficile colitis. That's a common sort of hospital-acquired infection that can be really difficult to treat, and patients do often don't respond to antibiotics. And in those settings, FMT has been sort of the only sort of recourse, and they approved they got their product approved to sort of prevent recurrence of severe C. diff. This particular product, SER401, was developed using a community of sort of ruminococcaceae, and that species that have popped up again and again that we found to be enriched in the patients who responded to immune checkpoint blockade. And we wanted to see if giving this pill instead of the sort of standard FMT prior to immunotherapy in patients with melanoma would enhance their response. So in order to test this hypothesis, we were sort of very thoughtful about the design of the study, because many of the studies, all of the studies that I've shown so far, even in the prospective setting, they've been single arm studies, meaning that they don't have a placebo control arm. They're just doing the same treatment to every single patient within the trial. And obviously, within the context of clinical trials, the placebo control and the randomization into those two arms is really, really critical. We initially had a comparator arm with who are going to get sort of the standard of care FMT or gold standard FMT. This also started to occur during the COVID-19 pandemic. And so we actually ended up sort of scratching that arm, and our accrual was quite limited by that. But we did end up going with the two arms, basically one arm receiving the SER401, the microbiome modulation, followed by nivolumab, or in the other arm, the placebo control, so the placebo microbiome pill, followed by nivolumab. And what we found, and this was a phase 1 study, so basically we were mostly looking at just whether this was safe and tolerated and people didn't have major side effects. And we found that it didn't cause any more side effects. And all the adverse events really were associated with just nivolumab treatment, as again, everybody got nivolumab. We also took a look at the patient's gut microbiomes across multiple time points throughout the trial. And when we look specifically at that ruminococcaceae family levels, and here the dotted line basically represents 0, so where patients are starting out from, you can see that after they got the preconditioning regimen, and I should mention, in the microbiome modulation arm, the decision was made to give them vancomycin, oral vancomycin. This is a drug that's used to treat C. diff, among other things, basically to clear the space for the ruminococcaceae pill to sort of try to take residence. We gave them vancomycin for 4 days, and then we gave them the microbiome pill or the placebo. In the placebo arm, they got a placebo antibiotic, so no antibiotic, followed by a placebo microbiome. And then everybody got nivolumab. But you can see that this dipped in ruminococcaceae abundance after vancomycin treatment. That makes sense because the vancomycin in part was targeting that. But it didn't really go up in terms of the level of response or the level of abundance of ruminococcaceae like we had sort of hoped to see. And when we looked at the overall sort of microbiome diversity and composition, vancomycin treatment, unsurprisingly, greatly reduced the diversity of the bacteria that were present in the blood and present in the gut. After SER401, it sort of got back to normal baseline, but this is one of those things, it's really hard to know whether this recovery by the time that patients started nivolumab was back up to optimal levels. And I say that because although this trial was not designed to look specifically at the differences in efficacy between the microbiome arm and the placebo arm, numerically, there were lower rates of response within our microbiome modulation arm. Now, part of this is that the placebo arm, for whatever reason, the small trial had a pretty substantial response rate, 67%, but only 25% of patients in the microbiome arm responded to therapy. Now, we did note that in some data I'm not showing here, after vancomycin, we did detect some levels of sort of inflammatory markers that have been previously associated with poor immunotherapy response. Those did fade by the time the patient started nivolumab, but some of those signatures, like regulatory T cell signatures within the circulation, did persist a little bit after initiation of nivolumab therapy. Now, as discussed before, at the beginning of the trial, we made the decision to profile the patients based on their rumino level a priori, because the whole hypothesis was that higher levels of rumino was going to be better for immunotherapy response. But if we didn't look ahead of time and sort of split out the high rumino versus low rumino patients in equal distribution to the two arms, then we could potentially miss or sort of misinterpret our data if one arm happened to have all high rumino or all low rumino patients. And so we actually looked at their baseline rumino. And what we found was that for instance, the patient who had a complete response, this is the only patient in the trial who had a complete response, meaning all of their disease went away after treatment. The patient that had the complete response had the lowest baseline ruminococcacea level. So basically less than 1% of their gut microbiome was rumino. And then after vancomycin, everything was wiped out. But then afterwards, after they got the SER41 and then started the nivolumab, you can see all these different squares in different colors. They're separate and distinct species of ruminococcacea, and potentially suggesting that maybe it's the patients with low rumino at baseline who maybe stand to benefit the most and get the most benefit from rumino supplementation. We actually took a look back at some of our retrospective data in our cohort of 112 patients who had been treated with immunotherapy and TPD1 checkpoint blockade. And when we looked at their ruminococcacea abundance at baseline, just as a biomarker essentially, we found that the rumino high patients did tend to have trended towards better progression-free survival. This work was published in Cancer Discovery and was presented at the national meeting at the American Association for Cancer Research about a month ago. And I only put this up here to say that even though this trial didn't have tremendous sort of response to intervention, there's sort of ongoing understanding in the field that these questions about preconditioning regimen, about the choice of antibiotic, whether to use antibiotic at all, are the ones that are at the forefront of the field. And touching on antibiotic use very briefly, particularly broad spectrum antibiotic use around the time of immunotherapy initiation in melanoma, but also across disease sites, have been shown in multiple very large retrospective well-done studies to be associated with poor response to immunotherapy and poor outcomes. But perhaps more importantly, we need to know sort of how to pick the patients who stand to gain the most from the microbiome modulation, whether it's people who have low rumino to start with. These questions are going to be critical to sort of moving microbiome modulation from a purely sort of scientific concept to the clinics to help patients actually living with this disease. So to give some final thoughts, the microbiome clearly plays an important role in immunotherapy response in patients with melanoma. And every year we're getting closer and closer to sort of fully understanding the patient factors as well as the external factors that explain and underlie sort of the mechanism for improved immunotherapy response through the gut microbiome. And by continually sort of taking these lessons learned from the clinic back to the lab, testing it with more refined hypotheses with these mouse and other preclinical models, and then coming up with new sort of thoughtful clinical designs to test these new hypotheses. That's, I think, how we could sort of dream about adding a sixth pillar to the paradigm of cancer treatment in melanoma and beyond. And with that, I want to sincerely thank, first and foremost, the patients and families and caregivers who made time to listen to me right along today, and those who are online as well. I especially want to thank Dr. Byrd and Dr. Hall and Ritu for inviting me and giving me the opportunity and the privilege to present some of their work in the Wargo Lab. I want to thank the Fred Hutch and Melanoma Research Foundation staff for putting on such an impactful event, Dr. Wargo and all the sort of countless lab members and collaborators, and of course, to my family for being my most important support and purpose, and for putting up with all the long hours and late nights in the hospital and in the lab. And with that, thank you.
You can see why we wanted him to come talk. Wow, what is my first response? I went from my imagination to my prediction, which is 25 years from now, maybe, the discussion that Dr. Lee and Dr. Hall and Dr. Tachiki is going to have with a patient coming in with advanced melanoma is, here is what your immune profile is in terms of your response of your T cells. Here's what your tumor shows. Here's what your stool profile is. Here's what your reported diet is. Here is your prescription for curing you of your melanoma based on all of those factors. And the surgeon's out of the picture. And you and I would both agree, we would find something else to do other than surgery. So let me, there was a question from the audience, the virtual audience. One was they wanted to make sure that they heard that the probiotic study in there, the patients had less effective response to immunotherapy with probiotics. Just want to make sure they heard it right.
Yeah, so in that study that I showed, and that's just one of many studies that I've looked at this. In our retrospective look, we didn't find any difference, I should say. We didn't find any statistically significant difference in patient outcomes when we looked at patients who reported taking probiotics versus not. The data that I was sort of talking about after that was in the mouse model, where we treated mice, tumor-bearing mice, with probiotics that are commonly found, and found that it actually seemed to have a negative impact on tumor control.
Dr. Hall has been having that microphone, says, I'm ready to ask. Oh, you're going to pass it around. So who do we have? A question? We got time for some questions here. We got about 8 minutes. You have to have some questions in that talk.
I have a question. How is it that we can't grow the rumino? If it's a biome, do you need donors?
Yeah, no, that's an excellent question. So I think there's a couple of different aspects to that question. We like the trial that I just showed, that is a sort of a concoction of a couple of different species and strains of Ruminococcacea and some other spore formers that were initially isolated from patients' stools who had good response. Now, whether administering a single strain or single type, like one specific Ruminococcacea species, has also sort of been studied in some other contexts. There's a commonly sort of prescribed probiotic in Japan, I believe, CBM 588, which is something that there was a recent article a couple of years ago in Nature Medicine that showed that actually administering that, which is a single strain probiotic essentially, with immunotherapy enhanced response in patients with renal cell carcinoma. So people are looking into it. People are developing sort of ways to test it. I think the biggest problem and the biggest challenge again is that even if you know exactly what one species you want to target, that almost certainly is something that is present in the vast majority of us. And so it's really hard to track, number one, whether the bug that you're giving is getting engrafted and is actually leading to the whatever response you want to see. And it's really important. It's really hard to tease that apart from what already exists of that same species, of that same family in your gut. So that's why these sort of consortia or pill-based efforts have sort of garnered a lot of interest. The other thing I didn't really show that we are working on actively is the concept of targeted negative microbiome modulation. I mean, it's kind of a fancy word to say narrow spectrum antibiotics. We know that broad spectrum antibiotics do seem to have a potent effect in terms of decreasing response or worsening outcomes. But there are other papers that have shown that specific targeted antibiotics or specific ways to delete certain bacteria, certain bad bugs, may have a bigger impact than trying to add or supplement good bugs. So that's something that we're actively pursuing.
I have a question. So this is a great talk, and I think it's one of my high-level takeaways is, boy, this is complicated, but I'm glad we've got smart people working on it across the country. So the fiber story, that seems like the most actionable item is that, like, and obviously if you eat a tremendous amount of fiber, that usually makes people feel unwell. But, that doesn't seem to be too bad. I'm wondering, as someone who's been in this field, if you were to look ahead 10 or 15 years, do you think we're going to end up giving people microbiotic capsules, or do you think that diet, like a truly adhered to diet intervention, is actually providing a lot more than a single strain of bacteria? What would you predict?
I'm going to take a cop-out answer. I'm going to say both. I mean, I do think that, and of course, we'll hear all about the dietary supplementation and so a lot of the science that, is certainly beyond my level of expertise, beyond what I've presented here today. It certainly seems like fiber, among other things, do play a key role, whether it's the fiber itself or whether it's the fiber's impact on the gut microbiome. I think, it's hard to tease apart, but certainly as actionable items go, I was talking to one of our melanoma surgeons who's deeply involved in this research as well. And I sort of asked her, like, what do you counsel patients on? Like, how do you tell people, like, how to sort of interpret this data in a meaningful way? And, it's a dangerous road to go down to sort of be prescriptive about what you should and should not do based on some of these studies that are retrospective, that are in mouse models, all that. Having said that, there is a daily recommendation of fiber intake for a reason. And so what she tells patients is there is some data to suggest that immunotherapy response can be enhanced with good fiber intake. It's good for your health anyway, so maintain it. And then in terms of probiotics and other things, Jen and Ashley and others have told folks, you know, for the most part, it doesn't seem like there's any good data for any one of them. And we generally would say just maintaining a healthy diet, healthy weight, and exercise. Those are the things that sort of, I think we'd recommend in 2024.
Other questions? Right, Center, we'll get a microphone to you right here. While that microphone's going over, you can see we have these talks on either side of lunch for a reason. I think the thought-provoking part of even conversations during lunch might be included.
How much fiber is in our lunch that we're offering today?
Actually, we've got 3 different salad choices, right? Salads usually have a component of fiber, so I think before we knew some of this content, Ritu already was omniscient about this. Your question.
Hi, so this is a very interesting topic. The microbiome was recently this documentary on Netflix. If you watched it, they touched on the topic of microbiome, how it affects certain dietary problems, but also like mental problems and so on. So we talk here about prevention, and the talk was amazing. And since I got cured from melanoma on my calf, I kind of adopted this vampire lifestyle. And my dermatologist sometimes says like, maybe it's a little bit too much. Nevertheless, my question is, can we hypothesize that some people, and that might be a big stretch, that depending on your microbiome, some people might never develop cancer, even if they have this first cell, that because of their microbiome, it gets destroyed early on. Is like the microbiome the answer to most of our illnesses? Can that could be an idea for the future?
That's
Yeah,
a
thank you.
profound question.
Yeah, absolutely. And that's a topic that I didn't really have time to address, but that's something that Dr. Wargo certainly espouses, which is the idea that we're not doing all this research just to improve immunotherapy response in patients with advanced melanoma. I mean, of course, that is a huge part of what Dr. Wargo and others have spent many years looking into, but really the idea is to head towards prevention and cure. And to your great point, maybe the microbiome, something that we sort of don't think about necessarily all the time, take for granted in terms of our dietary intake and other habits, may be contributing to cancer progression, maybe contributing to oncogenesis. There's, of course, within not just melanoma, but certainly within the colorectal space and others, there's a huge incidence, huge increase in incidence of young onset colon and rectal cancer that we still don't have a clear answer to, but it wouldn't be far-fetched to imagine that it's something like diet and potentially the dietary effects of the gut microbiome. I think, you know, one thing that I've learned over the last 2 years, just being sort of immersed in this world, and again, I should clarify, like, I'm still just a fellow for another month and a half. So I'm involved in the research, and I've been sort of trying to be an avid learner of the field, but I'm just sort of bringing what's out there in the literature for the most part to discuss with you guys. But having said that, I wouldn't be surprised to see more headway made into prevention within the gut microbiome space in the next 1 to 2 decades.
So I think we're right on time. Let's go ahead. You have a burning question? All right, we have a burner. And while he's getting the microphone, there are extra bagels and breads from this morning. Please take him home to. Yeah, take them if you'd like. And go ahead and ask your burner.
Okay, throughout my lifetime, I've noticed an alarming increase of people using pills for for all sorts of different treatments. The antibiotic is just going like crazy. I've been overseas and I've seen people just popping them like pills daily, and that's destroying the biome. Do you think that has an effect on the increase of cancer rates?
Yeah, I mean, that's a good question. It's certainly, I don't know the epidemiologic data, but I wouldn't be surprised to see that antibiotics, certainly the common ones, are being more and more prescribed and more readily available. That is something that actually one of the melanoma surgeons did counsel patients on in that way, in that sense, is that, you know, if you are diagnosed with melanoma or you're sort of living with the idea of potentially needing immunotherapy or other therapy for melanoma, that in general, obviously, if you need the antibiotics because of an infection that's ongoing, of course, that has to come first. But some of the antibiotics that get prescribed sort of pretty freely for a common cough and other things, she sort of counsels patients to say, let's just take a sort of careful look at why and who is prescribing these for you and for what reason. And that's something that I think, you know, antibiotic stewardship in general has sort of required a lot more attention these days with the increasing incidence of multiple drug resistant bacteria in and out of the hospital. And I think it is another piece of the puzzle, much like the fiber and dietary stuff. I think the antibiotic use is certainly something that we have yet to fully understand.
Great. So we're going to break for lunch back at 12:10, and we want to thank Dr. So and all of our morning speakers. Great talks. Okay, I think we've got most people back in. We're going to try to get started pretty much on time. Okay, everybody go ahead and get comfortable in their seats. Great. Well, welcome to the afternoon. It's going to be an exciting afternoon. We've got lots more to come. And as we gave you a sneak preview, Ray Palko is going to be talking to us about the topic is a fairly general title, nutritional supplementation, but I've heard him speak, and it will be a very educational and probably a very colorful presentation. So Ray is a clinical dietitian here at the Fred Hutch and works with a lot of our patients. And Ray, take it over.
All right, good afternoon, everybody. I got the coveted post-lunch crowd, so hopefully you're a little sedate and relaxed now, won't be too tough on me. But thank you for the introduction, Dr. Byrd. My name's Ray. I'm one of the dietitians here. I don't see any of my people out there yet. I know one of them's still eating, but just a show of hands, have I seen any of y'all in clinic before for a nutrition visit? Anybody recognize me from a one-on-one visit? Okay, I know there's at least one of them in there still eating lunch, so good deal. Yeah, and so today's topic, it was Doctors Byrd and Hall had brought to me. I think they said it was from a patient sort of request, wanting to talk a little bit about nutritional supplementation. My disclosures here, I am an employee of Fred Hutch. I receive no compensation, financial or otherwise, from any supplement manufacturer. And there really should be a third disclosure point that I missed here, but that would be that this talk is really going to be for educational purposes, not intended to specifically tell anyone that they should take XYZ supplement or they should not take ABC supplement. But just as a little thought experiment, I'm going to ask for a show of hands here. Who believes that by the end of this, they are going to want to be taking more supplements? Please raise your hand. Okay, and who believes that by the end of my talk that they will be thinking they may want to take less supplements? Please raise your hand. All right, let's figure out who's correct. Yeah, the outline of my talk here, and I may get rapid throughout. I'm sorry. I wish that I had the full day with you all. So I'm going to try and crunch a lot in. We got to do some quick background so we're all on the same page. Want to talk about supplements and cancer risk, and then talk about macronutrients, micronutrients, fiber, and probiotics. All of these from a supplemental versus whole foods angle. So supplement definition, dietary supplements are intended to add to or supplement the diet, and they're different from the conventional foods that we eat. This is just a list of some common categories of supplements, which can include vitamins, minerals, botanicals or herbs, botanical compounds, amino acids, or live microbials, which that's going to tie in a little bit with our keynote speakers talk. Right, some really important things for y'all to know. The label, right? Whenever you have a nutritional supplement and you're looking at that label, the manufacturer, i.e. the person who is making money off of your purchase of this product, suggests the serving size. That doesn't mean that that's right for all of us. Your provider may tell you that a different amount is right for you. In terms of effectiveness of dietary supplements, some supplements can improve health and manage certain conditions. Vitamin D and calcium, for instance, for bone loss, this can be really important. Folic acid, key constituent of the prenatal multivitamin to help lower certain birth defect risks. Many supplements, however, need more research and study to figure out if they have any value. And this bolded sentence is really important. The Food and Drug Administration does not determine whether supplements are effective before they are marketed. I chose to leave out any slide talking about the Dietary Health Education and Supplement Act of 1994. Anyone who really has a curiosity about the supplement industry, I would encourage you to type that into an internet search bar and read a little bit more about it. That was the last passed legislation in our country governing supplement marketing, et cetera. And it's really interesting when you read through it. Certain angles talk about for the protection of the health so they can access their supplements. Other angles talk about the financial boon and the amount of GDP generated by these supplements. And the act was passed by someone who lived in a state that manufactures the most supplements. So I leave that to you all to be savvy and think about that. More important stuff, safety and risk. So some supplements can interact with some medicines, and that might be problematic. An example would be vitamin K in anyone on earlier generations of blood thinners like warfarin. Antioxidant supplement. When we hear antioxidant, we think that's good, right? So another thing to think about with your nutrition, break out of the good and bad, black and white paradigms that we're so often focused on. Because antioxidants, when we're getting them through our food, are a wonderful thing. But we have retrospective research in the breast cancer world that high-dose antioxidant supplements probably actually decrease the effectiveness of those chemotherapies. Quality also. You want to seek a product with third-party testing. I've got the 3 most common verifiers there, their pictures put up. So it doesn't guarantee that it's a good supplement or that it is safe or effective, but it indicates that what the manufacturers said they put in the bottle is actually there, and that it's free of contaminants. So that's a really good thing when you are getting a supplement to look for something verified. And just some other important to know pieces. I love this one bullet here. The term natural does not always mean safe. And I think that this is something really, whether we're looking at supplements or food or just thinking broadly of this natural versus artificial, chemical versus real. A very important thing to remember, y'all, cancer is a natural occurrence, right? So simply being natural in and of itself does not make something desirable or good. Before you take any supplements, these are some really good questions to ask yourself, ask your doctor or your other healthcare providers. What are the potential benefits, right? Nothing makes me cringe more than when I talk to someone, well, why do you take that? It's good. What are the actual potential benefits? Does it have safety risk? What is a proper dose? How, when, and for how long should you be taking that? This next point's really important too. Medicines, like a chemotherapy or the immunotherapies that we've been talking about, these must be approved by the Food and Drug Administration before they can be sold or marketing. That's a very important safety step. Supplements do not require that approval. On this page here, and sorry if that's sloppy, there's a couple spots where I forgot to erase level 2 header. I'm sorry. I've been really busy in clinic. This slide here, the website address up top, this would be a great exercise for any of y'all if you're taking multiple supplements, and especially if you're in that head scratch space. Why am I taking this? Someone told me this. This is from the Office of Dietary Supplements from the National Institutes of Health. And they've got this supplement and medicine record tracker that can be a great thing for y'all to go through the pill box, the pill drawer, or as we get older, it turns into a pill cabinet for some of us, and tally down these things and just take a look at that. You know, some of this stuff is good just for recognition. What does it look like? How much is the dose? But I'd want y'all to really think about the columns. Why am I using this? And who told me to use and how to contact them? And then we may get to a space where we're taking a lot of supplements that we may realize, maybe I don't need all of this. Okay. As far as cancer risks go and how we try to work on lowering our cancer risk, this information is from an amazing group called the American Institute for Cancer Research. Every 5 to 10 years, they re-release their expert report, which culminates in a set of 10 guidelines that we can all follow to try to lower cancer risk. One of these 10 does recommend for cancer prevention, do not use supplements. So these 3 main points here, do not use supplements for cancer prevention. Kind of, as I said, that relates to the research data. We are not seeing any robust data showing supplements lowering cancer risk. Aim to meet your nutritional needs through diet alone. This is where my talk really starts to blend in with the previous keynote speech. We know that foods can help lower cancer risks, certain types of foods, and it's nothing exotic. It's no weird berry that's only uncovered in the Amazon. It's no strange combination. And actually on the AICR website, they have one page showing what they call foods that fight cancer in terms of reduction of risk. 80% of that list is foods that grow in Washington state. So it's stuff that's around us and available to us. And then lastly, we advise against the use of supplements as, we advise against the use of supplements as protection against specific cancers. This is actually starting to harken back to some of the data that was looked at. There has been interest in dietary supplements as forms of cancer treatment or prevention. And vitamin A and lung cancer was an interest. And there were clinical trials where patients with lung cancer were supplementing vitamin A, and the trials were halted because the supplement group's cancer grew more aggressive. Prostate cancer, selenium and vitamin E were of interest because data shows us that men walking around with low blood levels of selenium and vitamin E have higher prostate cancer incidence. And then in the SELECT trial, when they supplemented that, the tumors grew more and they halted that trial. So it's really, you know, we know this much of more than this much of knowledge that there is about health overall. So sometimes, and I know it can feel frustrating on a human and a patient standpoint to be like, what do you mean you don't know? But do no harm starts first. So, you know, that's where we're going to be cautionary with some of this stuff. But with things like a whole foods and more plant-leaning diet, we have all the evidence in the world that we need to know that that's a benefit to most folk. All right, now let's shift over and talk a little bit about the macronutrients. So these are the nutrients in our food that provide calories and give us energy. The 3 macronutrients illustrated best in the cartoon here are carbohydrate, protein, and fats. And I picked that cartoon because it shows you that, like, again, food is much more than just this XYZ thing. And so the cool parts on the Venn diagram, when you see that some foods have carbs and protein, some foods have protein and fat. And then in the very, very middle, if that is whole milk, 1 or 2%, those are the only foods out there that actually have carbohydrates, protein, and fats. And then we stop and think about, well, milk within the animal kingdom, what is its primary role? Infant's first food. So of course it would contain everything that we need. Macronutrient supplementation. Not super often recommended. Let's see, this top bullet here. Macronutrient supplementation only indicated if you can't eat enough food to maintain your weight and support your regular activities. By that meaning, basically, you can have your normal functional life, whether that's needing to get to school, to work, get kids to school, get older kids to work, or, you know, some of us in the sandwich gen doing all of the above. You know, and then your physical activity that you want to do, your exercise to help promote your best health, etc. If you can eat enough to take care of all that, you don't need a macronutrient supplement. Now, macronutrient supplementation options are going to include 2 main forms, a liquid nutrition shake and whole foods-based smoothies. The liquid nutrition shakes, different from protein shakes. Let's take a little comparison here. This would actually have a lot of applicable information to any folks going through treatment right now who may have had unintentional weight loss, may be undernourished, and may be needing to get more calories in. So that is where you want to aim for the liquid nutrition supplement, which is going to provide you greater than 200 calories and some exceed 500 calories. It'll provide all 3 macronutrients and micronutrients and what are thought of as complete nutrition, meaning that technically it has everything a human would need to survive in it. So these are products like Ensure and Boost. They're varying different things that they make, and Orgain is another brand as well. There are plenty other brands out there. These are the most common you'll find. The protein shakes are under 200 calories, only protein. Most of them have artificial or synthetic sweeteners, and they may or may not provide micronutrients, and that would be considered incomplete nutrition. So this is much more like if someone just needs some protein where that is appropriate. But now the tricky thing, and this may seem like such minutia to y'all, but inside the dietitian world, the protein shakes often curb hunger. And that's not a good scenario for someone unintentionally losing weight when we need them to get more nutrition. So often, you may hear from other providers, generally, they say, ooh, have Ensure. And then as patients and normal folk, we just pick up anything in a bottle that like has a couple weird things in the ingredient list and go, I have Ensure. And it's like, so there is this difference. And if you're in a situation where you need to know the difference, I hope these guys are referring you to us. All right, examples of the protein shakes include Premier Protein, the Ensure or Boost High Protein, Muscle Milk, etc. When would we want to supplement any individual macronutrients? Carbohydrate and fat supplementation, rarely ever recommended. We can get plenty of that in the food we need. Protein supplementation, often recommended during cancer treatment to help maintain lean body mass, and possibly for very physically active individuals or elderly individuals. And this will take a form of protein powders or shakes. And here's just a list of your whole foods protein sources. So any type of animal flesh, red meat, poultry, fish, eggs or dairy, beans, lentils, legumes, including soy foods, which just a quick plug on that. Controversy for females. Oh, soy causes breast cancer. Not accurate. Soy actually decreases breast cancer risk. Controversy for males. Ooh, does soy feminize? Totally not accurate. These whole ideas of soy turns men into women. I say, look around the world. Where do they eat the most soy? In a country that instituted a one-child policy. Stop and think, is that really feminizing the men? No. All right, and then nuts and seeds. And then in terms of medium protein, our whole grains and some of our vegetables contribute protein as well. Okay, the micronutrients. This is what we most often think about with supplementation. We need this in relatively small amounts. These are vitamins and minerals. And we want to be thinking about the DV, that's the daily value. That's what you'll see on the supplement bottle. And then also thinking about the UL. That's the amount. If you take over that, you have a toxicity risk. Let's see, micronutrient supplementation will be recommended if the diet is deficient in any specific micronutrient or if there's an identified blood deficiency. And there really is no value to supplementing micronutrients above the daily value and potential negative consequences. There's a supplements facts label just to kind of give you all an idea. And taking something like a multivitamin can help protect against vitamin or mineral deficiencies if we're eating a lower amount of food during our cancer treatments. They're also valuable if we have a poorer diet quality, meaning we don't get fresh fruits and veggies. We're generally eating a lot of French fries and McDonald's. We still want to use the multivitamin as the bridge to get you to eat more veggies, but they'll be valuable then. Also, research has recently shown us that older adults, the mean age was 73 in this study, a daily multivitamin benefited cognition. So I have a few reasons why I take just a general daily multivitamin, and one of them is because I'm not getting younger. And when you select one on this percentage, do I have a laser here? That'd be cool. I don't know how to use it. The percentage spot, look for stuff that's close to 100, right? You don't want a supplement that says 10,000%. You don't want that. All right, your whole foods sources of vitamins and minerals are going to be all whole foods that you eat. And when I say a whole food, a delineation here, we've got two types of food, whole and processed. Whole foods look like they have a home in nature when they're on your plate, like broccoli, it looks like a shrunken tree. Processed foods arrive on your plate in a shape, a size, and or color that does not occur anywhere in nature. When you're choosing your whole foods, with red meat, poultry, and fish, iron and B vitamins. And this is just a scant list of what they provide. It's just what I could quickly come up off the top of my head. Dairy, calcium and potassium, fruits and veggies, vitamins A and C, nuts and seeds, iron, copper, zinc, B vitamins, plenty of others. So a diverse and balanced diet, similar to that one plate that we looked at earlier, that's going to be able to provide you all the vitamins and minerals that you need in adequate amounts, with the only exception being vitamin D. That's a little bit of an outlier. So most of us need a vitamin D supplement to keep our levels normal. Fiber supplements. This is a super busy slide. I should have really pared it down. But the point that I want to translate here is that fiber supplements, different ones can have different type of functions in the body. The most often time I see folks needing a fiber supplement is like maybe, honestly, probably constipation is like a main area where we think, okay, we want some. And if you look at these 4 different clinically meaningful designations, the top and the bottoms are the ones that would actually have a laxative effect. So the big takeaway here is going to be like, if you think you need a fiber supplement, ask yourself why. And if it's for a specific functional purpose, like please talk to one of your healthcare providers and ideally ask them, say, what did the dietitian have to say? Because they did have one instance, and it was not with any of our doctors here today or this group, but I had a really constipated patient that was accidentally recommended a type of fiber supplement that further constipated. So always ask for the dietitian's take, please. And here are your whole foods fiber sources. So plants. And again, the more whole the plant, the more that it looks like nature, the more fiber that it's going to have. And another thought here, as we talk about supplements versus food, right? The supplement will only give you X, Y, Z, whatever thing. But this food, this plate up here, absolutely adequate fiber. Probably more than 100% of the daily value of vitamin C is on that plate. There is a lot of phosphorus in the quinoa. There's the B vitamins in the chicken. So again, you know, when you take a supplement, that's all you get. When you eat food, you get a whole lot of different things. Probiotic supplementation was sweating for a moment during the keynote if we were going to clash with one another, but we harmonize perfectly, right? So your probiotics are those good live bacteria that's found in certain like yogurt and other fermented foods. And while the interest is really growing here and it's promising, we don't encourage what I would call self-replication of clinical trials. So really, if you were thinking, I want a good gut microbiome, I want you eating a diverse array of plant foods, and that is going to help take you there. Another super busy slide, but some good points just to know about probiotics. Some evidence that they can help for some things. Some promise shown, more research needed. In bold, especially if you're going through cancer therapy. Right now in this cohort, it's probably mostly all immunotherapy, not the same immune risks that we see in chemotherapy, but there are spaces there and there are some case reports where damaged gut integrity and eating too much yogurt all of a sudden turned into some bacteria in the bloodstream. Different effects in different bodies. And if considering a probiotic supplement, definitely want to talk with a provider first, and you never want to replace a scientifically proven treatment with something unproven. All right, your whole food sources of probiotics are going to be any fermented foods in the dairy world like yogurt, kefir, or cultured sour cream, and then fermented veggies, sauerkraut, kimchi, other things along these lines. These are some excellent resources. So at the top is the NIH Office of Dietary Supplement page, where y'all can get a ton of information about these individual nutrients and how much does your body need versus what is too much. The middle bullet, an organization on the other side of the country, Memorial Sloan Kettering, a really great cancer center there. They have a wonderful website here. And then they also have a free smartphone app called About Herbs that you can download. And that's going to provide you a lot of really strong information about the yays and nays of these things. And then last is NatMed, which is like the authoritative source, but it does require a subscription. All right. I don't know how much time we have, but make me sweat. Hit me with your questions.
That was a great talk, Ray. What time for maybe one question, then of course after, are you able to stay after? You might not be here to the end of the conference. We'll see.
Yeah, I don't know if I'll be here the whole time. I
Okay.
might hang around a little bit.
You can grab
Depends
it
on the
aside.
questions. Maybe we're on.
Question?
Here, quick question. What about mushrooms?
What about mushrooms? Thank you for that question. This is going to be another one similar into the probiotics in one of these spaces where we don't necessarily have a ton of the rich and robust data yet. And so in actual day-to-day life over in the clinic, when a patient says, I want to take or I'm taking XYZ, then when they tell me that, I go and take it. I most often wind up kind of kicking it down to my pharmacy colleagues because they have the best access to all the different databases and to know if something may interfere with the treatment or not. And when it comes to the mushroom supplements, it's like a mix back and forth with all the different treatment types. Sometimes the pharmacists are like, ooh, stay away. This may have a massive interaction. And other times it's like, okay, it's not going to be any issue. So, and also the thing about mushrooms too, when I simplify all my talks and say our food comes from either a plant or an animal, that's a lie. Mushrooms or fungi is an entire different kingdom out in the natural world. So there's a lot more that we need to know about these. And I don't feel that I know a strong enough amount that I'm ever confidently telling someone, take this mushroom supplement. One of the few whole food sources of vitamin D, though, if the mushroom was exposed to ultraviolet light, because mushrooms can make their own vitamin D just like we can. So interesting.
We actually are on good time, so we have a few minutes. Other questions? Right there in the middle.
So my question is about turmeric. You said not to take any supplements for cancer prevention. Turmeric is one of those ingredients that been studied in countries that use a lot of turmeric, and apparently the cancer rate there is smaller. So what is your take on turmeric supplementation?
That's a great question there. So, and especially I like how you mentioned about like other countries that might be utilizing turmeric more often and lower cancer rates. So with that, we don't want to think about only the turmeric, but what the heck else is involved. And often it's like countries in like South Asia, you know, in India. So if we think about their diet and we think about, again, that dietary fiber and how valuable it is, well, a lot of the meals, including the turmeric, are like a lentil dal with maybe some whole grain roti. So that's one of those things that we kind of got to pull out the different pieces. What's really helping there? And it's probably the overall combination of all of the above. Now, turmeric supplementation is actually something that's one of those ones. It's a little mixed by the cancer types, but in the breast cancer world, we actually have data that turmeric, at least in test tubes and petri dishes, turmeric can inhibit the effectiveness of some of the most common chemotherapies for breast cancer. And now another thing to think about in all this too is that the bioactive substance in turmeric is called curcumin. And so there's a big difference between like taking a curcumin supplement versus eating and cooking with turmeric. So I would never discourage anyone from eating any type of whole food. Unless you don't like it, then don't eat it because life's too short for that. But yeah, in the supplementation area, I can't tell you absolute yay or nay either way on it. And if you wanted to supplement with it and thinking of lowering your cancer risk, just be sure that you're eating plenty of good plants.
Yes, sir.
I was early on in my journey encouraged, because of a predisposition to colon cancer, encouraged to take aspirin. Do you have any comments about that?
Yeah, I am not 100% certain where the current medical recommendations are now. I do know that aspirin has been recommended to help with lowering some risks. I guess I actually don't really have a comment because I don't know. I'm sorry.
A question about, in general, if somebody's looking at, I want my energy to be higher, or I want my mental acuity to be at its max. If you get those generic questions, how do you address that?
Yeah, that's a great question. And I mean, first, I would answer it with other questions and asking about, okay, well, tell me a little bit more about your overall lifestyle. I want to learn about your diet pattern. I want to know how you're sleeping, because all of these different influences can come in to affect where our energy lies. And, the thought of like, well, I want to supplement for energy. An important thing for us all to know, the term calorie, when you look at a nutrition facts label or someone tells you that's a 500-calorie meal, the term calorie means a unit of energy, right? So, and then the micronutrients sort of assist in the body processing that type of energy. So there's no magic energy in a bottle. I mean, the coffee's well, as close as you get, but once the buzz fades, then you're more tired anyway. So yeah, if you're just generally like fatigued and not having a lot of energy, it's a big conversation about a lot of different things to see, you know, what change might be warranted that could benefit you.
Yeah, time for one last question.
I have a friend who is not a big fan of broccoli, those miniature trees. I'm curious. We've seen a lot of this friend is also very active on social media and sees a lot of ads for athletic greens or some of those green powders. What is your opinion on the effectiveness of that way of receiving some of your fibers and
I love the
nutritionals?
question, and I have to give you like two answers actually. Initially, just to say that if your friend does not love broccoli, but they enjoy cauliflower or Brussels sprouts or cabbage, so that's the cruciferous family of vegetables, which is identified as helping lower cancer risks. But the great thing is that all kind of came from one origin plant, and then really savvy farmers over millennia have been picking apart different properties, and that's why one plant led us all of those. So if you hate broccoli and love cauliflower, like don't buy broccoli, like keep it as far away from you as possible and hammer the cauliflower. In terms of those type of a supplement, like the athletic greens or these like fruit and vegetable powders, yeah, they really, if I'm going to be real, they annoy the bejesus out of me. Just like, let's stop and think with our rational brain. And when you see something like there's one called Juice Plus, and it's these little capsules, and it's like one capsule is the equivalent of 5 servings of fruits and vegetables. Just put the two next to one another, and like do the little, like one of these things is not like the other. And especially when we're talking, you know, back to the microbiome talk, that dietary fiber is such an important constituent that doesn't exist in these little supplemental forms where, as opposed to eating the whole food. And my final point, gosh, I could talk all day. I should take this over. Sorry, it's the nutrition conference now. No, my final point is just that if you take a supplement, right? Let's take vitamin C, for example. Is vitamin C the thing that is really so beneficial in our body, or is there something else in all of the vitamin C rich fruits and vegetables that we as humans haven't even discovered yet? So always, you know, to borrow a line of all places from the Coca-Cola Corporation, you can't beat the real thing.
Thank you. Thank you, Ray. That was like, he could go all day. Do we have Debbie? Is Debbie coming from the front? Oh, she's back there. Okay. So May is Melanoma Awareness Month, as you may or may not know. We've tried to have this in May in general for that reason. Of course, the Melanoma Research Foundation and others think, look, guys, spread it out over the year, not just May, but we have stuck with our May. I talked about the partnership with Melanoma Research Foundation that's been there since the beginning. We feel like this is a wonderful partnership, and we want to give Debbie Churgai a few minutes to talk about MRF and maybe our relationship and how our audience could get involved with MRF. Thank you, Debbie.
Thank you. Yes, I just want to thank you all for being here, taking time out of your day, out of your weekend. I want to thank our amazing presenters that we've had today. I want to thank the Cancer Center for partnering with us. We've been doing this together for several years now with them. I want to thank Ritu especially for all the work she did for this event today. So and thank Dr. Hall and Dr. Byrd as well. But as you mentioned, we are in partnership to present this symposium for you today. But we could not do it without the help of our sponsors. And our sponsors, Merck, Novartis, Bristol Myers Squibb, Pfizer, Genentech, Castle Biosciences, Iovance Biotherapeutics, Regeneron, Immunocore. They are the reason that we're able to put on these events today. If you see, there are some representatives of these businesses here today. If you see them, please thank them. They're the reason why we are able to do these things all across the country. So I'm just going to tell you just a little bit about the Melanoma Research Foundation. It's the largest independent organization devoted to melanoma, committed to the support of medical research to develop effective treatments and eventually a cure for melanoma. The MRF also educates patients, physicians about the prevention, diagnosis, and treatment of cutaneous melanoma and also the rare subtypes. And it's dedicated to advocate for the melanoma community, helping to raise awareness of this disease and the need for a cure. Our website is an amazing resource of information, melanoma.org. I definitely encourage you to check it out. This is our founder. Melanoma Research Foundation was founded in 1996 by Diana Ashby, who was diagnosed with melanoma, and after a 3-year battle realized that there were no options for new therapies in clinical trials. If you know the history of clinical trials and research, it's amazing what has happened in the last few years, but before that, there really were very few therapies available for melanoma. And that is her husband. Our mission statement is to eradicate melanoma by accelerating medical research while educating to and advocating for the melanoma community. The reason why we have those words bolded is our organization, those are our 3 pillars: research, education, and advocacy. Right now, you are at an education event. I am the education program manager at the Melanoma Research Org, so putting on these events and some other things that I'm going to talk about, this is what we do. This is just a snapshot of some of the amazing things we do throughout the year. We host 19 5Ks across the country. We 2 signature galas, one in New York, one in Denver, 6 or 7 patient symposiums every year. And we bring patients and caregivers to DC to talk to their congressional leaders about what is needed and why more funding is very necessary for melanoma. We also host a pediatric or young adult event each year and a rare subtype event. We just had an ocular melanoma event in Boston 2 weekends ago. This is just a snapshot of something. This is for our research pillar. And again, since this is an education event, I'm going to talk a lot more about education, but our research is absolutely amazing. We have awarded 31 grants in 2023 and have funded over $25 million in research. And actually that number is going to increase. We're just updating these numbers. They should be updated in a few weeks, but so we've done incredible work for the research melanoma. This is some of our educational resources. So we have a ton of educational materials. We do webinars once a month. We have animated melanoma patient videos, patient and caregiver symposiums, and we have information on rare subtypes and more. If you go to our website and you go to the Education Institute, we have a learning platform, and I'm going to go over all this a little bit more with you. Educational materials and our animated patient videos. This is just some of our materials. We have 26 pieces of literature. By the way, these are all free to download and order. So we have schools, dermatology offices. If you're hosting an event, go to our education material. On the bottom of the page, you can order as many materials as you want for free. Topics include cutaneous, OM, mucosal, youth prevention, pediatric, and clinical trials. And here's just another slide, some of our materials that, again, free to download or free to order. As I mentioned, we have these amazing animated patient videos. I always recommend these to family members, caregivers, if you want them to learn a little bit more about melanoma. These are all less than 10 minutes. They're really eye-catching. They're done really well. And we are actually creating one on immunotherapy as well this year. But these are the 6 that we have so far. Oh, sorry. Did you want to take a picture of that? We also have a learning platform. So on this platform, we have over 64 videos now. We have all of our past patient and caregiver symposia. So if you were able, if you really enjoyed this one, you want to see what some of our other symposias had, you can check them all out there. All of our webinars that we do live on this site. And we also have a melanoma educator course that anyone can take. As I mentioned, we host webinars once a month. It's called Ask the Expert webinars. And these webinars usually have one or two experts, and then we always include a patient as well, because of course the patient perspective is so important. And I was just talking to someone today about, we would love to do a caregiver one as well, because the caregiver role is so important. So I'm looking to create a caregiver webinar soon as well. We have one, the next one is next Wednesday, and it is about sun safety and early detection of melanoma. We have an amazing patient community forum. So this is where you can talk to people about any of your concerns. They talk about grief, new therapies. It's been going on for years too, so you can look back and see there's some threads that have been going on for over 15 years. But lots of amazing topics. So if you have a question and you're just like, I don't know who else to ask, I need to talk to people in my community, our patient forum is definitely the place to go. You can see some of the topics include lots of different areas. So advocacy, as I mentioned before, every year we bring patients and caregivers to the Hill to meet with congressional leaders. We also work with legislators and policymakers to help increase funding for cancer, specifically melanoma research. We just held our annual advocacy day about 2 months ago. But if you would like to attend our advocacy day, it's an amazing event. Please reach out to me and I can connect you to our advocacy director. It's held in Washington, D.C. We do have about 10 spots for scholarships and they go quickly, but it really is such an uplifting and amazing event. We have a ton of campaigns, prevention and awareness campaigns. Our biggest campaign, called #GetNaked, our new spokesperson, which we just announced May 1st for Melanoma Awareness Month, is Miami Dolphins running back Raheem Mostert. And as Dr. Byrd mentioned, today, May is also Melanoma Awareness Month. So we have a ton of things going on this month, including an Instagram and TikTok filter we created in conjunction with Cancer. And it shows like your face is split and it'll show in about 20 years, progression of 20 years, what your face would look like if you didn't use sunscreen compared to if you did use sunscreen every day. I showed this to my 12-year-old and she was traumatized. So I know, guarantee she's going to be using that sunscreen every day. So check it out on TikTok and Instagram. We also have our mucosal melanoma campaign, I Get Dilated, and also our spot campaign for the pediatric community. We have cutting edge programming. We have a Curo's Vision platform, a breakthrough consortium, and the Mucosal Melanoma Initiative. And if you want to know about any of these, more about any of these initiatives and programs, definitely check out our website. Follow us on social media if you want to get more information on upcoming events or facts, or we love to share patient stories. So again, if you're willing to share your story, please come talk to me. And you're okay with sharing it on social media, but we're on everything. So please follow us for more information. And we are a nonprofit, and we are dedicated to the advancing the scientific understanding and treatment of melanoma, and every individual contribution is vital to our mission. We cannot do it without the support of our sponsors, but also individuals like you. Each mode of giving ensures that together we can continue to fund vital research and support services for those affected by melanoma, and we offer a variety of ways that you can give. Again, I want to thank our amazing sponsors for supporting us, for supporting patients and caregivers too. It's really nice to have big businesses that really want to support events like this that are for patients. And in the folders that we gave you today, you'll notice that there is an evaluation. please, if you could, if you could fill that out. There's also a link. I think they're going to send the link for the online if you want to do it online as well. But filling out these evaluations are really important for us, especially me, to see, you know, which topics you really like so that we can do more of those throughout the year, and to see which topics that we didn't talk about that you want to see more of, that we can do webinars for and things like that. So really appreciate it if you fill out the evaluation. We also, by the way, use some of your quotes. So if you do write something in the comment section, we share those with our sponsors. We share those with our board. Sometimes we'll share them. We won't put your name, but we'll share them on social media and things like that, to, you know, highlight that your appreciation of events like this so that we can continue them. And that's all I have today. Thank you again so much for being here.
All right. Next up, very exciting to introduce Dr. Zach Kadro. Dr. Kadro is a physician in our integrative medicine program and has naturopathic training, an ND degree, which was done at Bastyr University, and has gone on to do residency and a fellowship at UNC Chapel Hill. So I'm really excited to have him tell us a bit about our rapidly growing integrative medicine program, and really I'm delighted that he's here to join us today. Thank you, Dr. Kadro.
Thank you, Dr. Good afternoon, everybody. Thank you, Dr. Hall and Dr. Byrd, so much for the opportunity to be here to talk with you all about integrative medicine. I set the timer on my phone so that we have at least 5 minutes for questions at the end. So I probably have a lot more content here than we're going to have time to get through, but that's okay. I think the main purpose for today is just to give you an introduction to what integrative medicine and integrative oncology is, if you're not aware of that, and then to talk about our program here at Fred Hutch. And then all the details about specific programs that we offer or resources that we have that you can use throughout your treatment and in survivorship. We can go over all those details through our consultations. Okay, my conflict of interest disclosure. So I receive royalty payments from UpToDate for an article that I co-authored with our integrative medicine team here at Fred Hutch, which is called Overview of Complementary, Alternative, and Integrative Medicine Practices in Oncology Care and Potential Risks and Harm. And I'll be referencing that talk throughout the presentation, or I'll be referencing that article throughout the presentation today. So there's 3 objectives that we're going to try to cover over the next 17 minutes here. The first one is I want you to be able to define integrative oncology, to become familiar with the treatment modalities that are used in integrative oncology. And then the third one is to become familiar with our integrative oncology program here at Fred Hutch. So let's start with the definition. And really, if there's one takeaway, it's this slide to give you an introduction. So integrative oncology is a patient-centered, evidence-informed field of cancer care. And we utilize 3 categories of modalities to help people along the cancer care continuum. So the first one is mind and body practices. The second one is natural products. And the third one is lifestyle modifications, which would include physical activity and nutrition. And the goal is to optimize health, quality of life, and clinical outcomes, and to empower people to prevent cancer and also to become active participants before, during, and beyond cancer treatment. So that's kind of the big picture here of what we do in integrative oncology. So now we'll start to get into some of the details. Definitions here, there often a lot of confusion about what is integrative medicine, what's alternative medicine, what's complementary. But some of the phrases that you'll hear, so traditional therapies would be culturally based. So that could be things like acupuncture or Tai Chi or Qigong. Alternative therapies would be something that's used in place of conventional medicine. Complementary would be something that's used with conventional medicine. And then integrative medicine is just the coordinated use of evidence-based complementary therapies. This is a slide here about integrative medicine use among cancer patients and survivors. And the key takeaway here is just that it's very common. So 60 to 80% of US cancer survivors use integrative medicine. Some of the goals are to improve quality of life and survival outcomes, increase the efficacy of conventional therapies, to prevent and treat side effects of conventional therapies, and then to treat existing comorbidities. So the clinician's role in integrative medicine is to help to guide people on what works, what doesn't work, and what is safe, and then help people to be able to make informed decisions about how to appropriately use these. So going back to the definition, this is just a graphic that helps you to see things in terms of the three modalities or three categories of modalities here. So lifestyle, nutrition, and physical activity, mind and body practices, and then the natural products. So we're very lucky here at Fred Hutch to have a robust supportive care program. And you can see in this graphic here, there's integrative medicine, there's the pain management clinic, palliative care, psychiatry, pharmacy, social work, spiritual health, physical therapy, and nutrition. So there's a lot of different specialty care within supportive care that we can use to help people. So our program focuses on lifestyle counseling, symptom management, mind-body therapies, and then dietary supplement counseling. Ray gave a great talk about natural products. And so when you see natural products as part of integrative medicine, really what we're focused on is having informed discussions with patients, because many people come in already taking things. And so it's about understanding what people are taking and then counseling them on what may be safe, what may be a risk, and what to continue or discontinue at different stages of treatment. And there's a QR code there for our website. Okay, lifestyle. So again, I'm going to try to move fairly quickly through these, but so lifestyle risk factors, nutrition, physical activity, and sleep. This is from a website that Ray also mentioned, which is American Institute for Cancer Research. And so some of they list 4 bullets of some lifestyle risk factors. One is arsenic exposure in the drinking water. Our water is tested for that. Peculiar one here, taller adults have an increased risk of melanoma. Ultraviolet radiation from sunlight is obviously the primary cause. And then occupational exposures to chemicals. So plastics and other types of chemicals that people may encounter in the workplace is also a risk factor for melanoma. And then nutrition across the cancer care continuum. So we won't have time to go into a lot of the details today, but the high level view is that the goal while you're on treatment is to maintain the weight and muscle mass. And that's what Ray had talked about. And so we want to assess, is there unintended weight loss happening? Are there feeding challenges or challenges with the nutrient status? Assessing for extreme dietary changes after diagnosis. So some people will read on the internet and then all of a sudden want to make extreme dietary changes after they're diagnosed. And so we want to know about that. We want to be able to then help to counsel folks on what's actually appropriate given where they are in their treatment. And so the last bullet then is we want to involve a dietitian early on to help connect them with the appropriate care. So this is, I thought actually Ray was gonna do this in a little bit more detail. So this is a graphic that we love. We use this all the time. And this kind of gives you the big picture for nutrition and cancer prevention. Ray did talk about how you don't want to use supplements for cancer prevention. But the main thing here is there's a section over on the left which says, eat a diet that's rich in whole grains, vegetables, fruits, and beans. And so to really simplify everything, that's what we want the focus to be with the nutrition. It doesn't have to be complicated. Eating whole foods, basing the diet around plants is going to provide a ton of benefits. We have a great website at Fred Hutch, which is called Cook for Your Life, that has lots of evidence-based articles. It has over 1,000 recipes, and you're able to search that website for prevention, for survivorship, and also for side effects of treatment. So in addition to the support that the dietitians can provide, that we can provide in integrative medicine, there's also a great website that you can access to get evidence-based nutrition information to help you along the way. Okay, let's switch to physical activity here. So again, the high level view with physical activity is that the goal is you want to maintaining weight and muscle mass. Physical activity can help to do that. We want to assess for unintended weight loss and muscle loss, assess for physical limitations and exercise safety. And so oftentimes we'll be looking at labs. Are the labs appropriate to engage in physical activity? And then if not, what modifications can be made? And then also involving specialty care. So we have physical therapists, we have physiatrists that are here at Fred Hutch. And so we'll help to connect patients and send referrals to get additional support in the physical activity area. What are some of the benefits of physical activity along the cancer care continuum? It can help to reduce anxiety and fatigue. It can help, actually, it's like the best evidence-based treatment for fatigue. Obviously, fatigue, there's so much that goes into it, but the evidence overwhelmingly shows that exercise is a great way to address fatigue. Improving self-esteem, improving positive feelings, improving heart health, helping to maintain a healthy weight, and then boosting muscle strength and endurance. This gets into a little bit the details here about what the evidence shows. And for general health and also for cancer prevention, this goal of 150 to 300 minutes per week of moderate intensity physical activity is the same for both of those, for general health or also for cancer prevention, or 75 to 150 minutes of vigorous activity. So again, we want to make appropriate recommendations based on where you are along that continuum and then adjust from there. But certainly for prevention and in survivorship, when people are in good general health, those are good targets. Lots of different ways to accomplish this. So walking, running, biking, swimming, sports, yoga. There's lots of online tools and resources. And then for sleep quality and sleep hygiene, this is one of the main areas that we help people with. So many people have disruptions in their sleep, whether that's due to, many things, but one of the most common ones is underlying anxiety or anxiety that's associated with the cancer diagnosis. Certain medications can disrupt sleep, but there's a lot that goes into it. And certainly sleep is foundational to just being able to approach all the challenges of life in the best way that we can. And so we work a lot with people to improve sleep. So some of the recommendations here, you've probably already read them as I was talking, but dark, quiet, and cool room, thinking about caffeine, exercise, and then there's some of the ways that we can approach sleep with gentle yoga, progressive muscle relaxation, breathing exercises, acupressure, etc. Okay, and then we'll transition into the mind and body practices category. So there's a lot here in the next few slides, which again, we won't have a lot of time to go into detail, but I again just want you to be familiar with some of the modalities that we use, and then we can figure out the details in the integrative medicine consultation. So this is a big category, but it includes things like acupuncture, acupressure, meditation and mindfulness, yoga, qigong and tai chi, massage, manual lymphatic drainage, hypnotherapy, music therapy, and there's even more beyond that, but this is a good list to get started. So it's a big category. Acupuncture, we use this for a lot of symptom management, and this comes from traditional Chinese medicine. It's been practiced for thousands of years. And it uses it's the insertion of thin solid metal needles at specific anatomical points around the body to stimulate, from the traditional Chinese medicine perspective, it's to stimulate the flow of energy or qi. And from more of a biomedical perspective, it's really to modulate specific neuronal or cortical pathways. So acupuncture in the oncology setting, as I mentioned, we use this for a lot of different side effects. One of those would be pain management, nausea and vomiting, chronic musculoskeletal complaints, things like hot flashes, fatigue, stress and anxiety, neuropathy, or even like dry mouth from radiation and sleep. So a lot of different uses there. At Fred Hutch, typically a course of acupuncture will last 8 weeks. It would be once a week for 8 weeks, and the session usually lasts 1 hour. Some symptoms can take 4 weeks or so before somebody will start to see improvement. So we always talk to people about that, you know, some things may improve right after the first session, but for other things, it may take a few weeks and to be patient with it. Acupressure draws on the same acupoint system as acupuncture, and it can be performed by a practitioner, by a patient or a caregiver. And you use the fingers or a device to apply pressure to specific acupoints around the body. And it can be used for many different side effects. Some of those are nausea, pain, stress, sleep, and fatigue. And we have a lot of handouts for acupressure and links to videos. We can show people how to do it in the clinic. Our nurse provides acupressure teachings, and so a lot of ways that you can learn about this modality. This is just an example from one of our handouts here. Large intestine 4 is used for pain. You can see it's a point located right here, and then you apply pressure in this area here. That's used for pain. Pericardium 6 is used for nausea. If you've ever heard of C-bands that people use for motion sickness, C-bands are basically drawing on this acupoint here, and you can stimulate it yourself. It's located on the wrist, about 3 fingers up from the wrist, and then you use your thumb and you press down in between the tendons, and that can be helpful for relief of nausea. Okay. I'm down about 3.5 minutes, and I said I would leave 5 minutes for questions, so I got to move through this. Meditation and mindfulness-based stress reduction. Let me just briefly talk about this. So meditation is an umbrella term. It refers to specific traditions and practices with evidence of effectiveness, and it has an ability to improve symptom management and improve the stress response. So letting go of thoughts, feelings, sensations, and external distractions. And some examples of this would be mindfulness meditation, transcendental meditation, and Zen meditation. So meditation and mindfulness-based stress reduction. So this is self-regulation practices that are focused on training attention and awareness to bring the mental processes under greater voluntary control. And this helps to support mental well-being, calmness, clarity, and concentration. So some common elements: we want to find a quiet location, a comfortable position, and then focus our attention on something, which could be our breath, it could be an object, it could be a sound or a mantra, and then letting thoughts come and go naturally without judging them and bringing our attention consistently back to what we're focusing on. There is a specific program that's been tested multiple times in research, which is called mindfulness-based stress reduction. And there is a group here in Seattle that teaches these courses. So we don't have time to go into the details, but MBSR is one of the well-tested methods to learn mindfulness-based stress reduction. Okay, the 4-4-8 breathing technique. This is one of my favorites. It's very simple. We use it a lot for sleep and for anxiety. And I teach a lot of patients this in the clinic, and then just recommend people do this for 2 to 5 minutes per day. And even really before anything, just knowing that your breath is always there. And by using a focused method, you can use your breath to help bring a sense of calm and relaxation to your body. So this is the 4-4-8 breathing technique. And again, not enough time to go into it. I wanted to maybe practice that with you today, but that's okay. All right, and then massage therapy, that's another modality that we use. I'm gonna skip through that. Yoga, that's another one. I'm gonna skip through that. Natural products, you had a wonderful presentation by Ray introducing you to the natural products category here. And some main things to think about are just the interactions that natural products can have with different modalities. So with surgery, they can affect bleeding and sedation. So oftentimes your surgical team will most likely tell you, all right, stop the supplements 1 or 2 weeks before surgery. But to just, repeat it here, we would reiterate the same message. So that's important. Let them know what you're taking. Stop them, well in advance before surgery. And then there are interactions that supplements can have with drugs. And this is very sort of detailed here, but the main idea to think about is that drugs are metabolized in the liver, and certain herbs can affect how the liver is metabolizing drugs and herbs. And so there can be interactions that we want to be careful for. So, okay, this slide here, the last bullet is most important, but it may not surprise you, but in the research literature, it's been studied like how is the communication between patients and providers around dietary supplements? And the main takeaway here is that many people don't even talk to it about supplements with their providers, but we want to encourage the discourse and the conversation about supplements so that we can have discussions about the risks and benefits and safety so that you can remain safe with what you're taking or discontinuing things that may put you at risk. So, okay, and then the last one here, cannabis and immunotherapy. Cannabis, there's widespread use of it. The American Society of Clinical Oncology recently published guidelines on cannabis in cancer care. And one of the takeaways from that I wanted to bring into the discussion today is that there's one prospective and one retrospective study that have shown shorter median time to progression in adults with advanced cancer on immunotherapy when they're using cannabis compared to not using cannabis. And then another one that was a retrospective that showed that cannabis use was associated with lower treatment response in adults with advanced cancer that were on nivolumab. So again, not enough time to go into the details, but cannabis is affecting the immune system, inflammation, and it may interact with the way that immunotherapy works. So you want to be cautious about that. So this is our integrative medicine team. We have acupuncturist, nurse practitioner. We just hired a medical doctor, Shannon Fogg, and a big team that's here to help support you. You can self-refer. Your providers can refer you. There's insurance coverage for our services. That's the main takeaway. We'll always screen people before to make sure that they have insurance coverage for our services. And then this is some contact information. Here we have a website. There's ways to get in touch with us. Okay, I think it's just about a minute over, but thank you.
All right, as planned, some time for questions.
Okay, cool.
You mentioned acupuncture and neuropathy.
Yeah.
Can you say a little more about that?
Sure. Yeah. At this point in the research literature, we do have some evidence that once chemotherapy-induced peripheral neuropathy, that's kind of the long phrase, but basically just neuropathy from a cancer treatment, that it can be improved with the use of acupuncture. So we do have some data to support that. And so we work a lot with neuropathy, and our acupuncture team has a lot of experiences helping people use acupuncture to help with neuropathy symptoms. We're testing that now in the prevention area. So does adding acupuncture while people are on treatment, does that help to prevent a neuropathy? So yeah, you're welcome. Thank you for the question. Yeah.
Is the cannabis also, are you also talking about if you take CBD to sleep at night?
Yeah, so cannabis contains THC, which is the compound that gives people the feeling of elation or feeling high. And then there's also CBD. And both of those are really, I mean, there's hundreds of compounds within cannabis that are being looked at for different medicinal purposes, but THC and CBD are the main two. And both of those seem to have some interaction. And actually CBD is more of the inflammation modulating or immunomodulating compound within the plant. And so that may be the one that is interacting with immunotherapy. Yeah, thank you.
Just read that. Sure. There's a somewhat logistical question about the acupuncture handouts. Are those available online for remote patients or for those interested?
Great question. Thank you so much. Yes, in the Fred Hutch website, there's a section, something to the effect of patient education or patient resources. And so if you just type in your search bar, Fred Hutch, patient education or patient resources, and type in acupressure, all of our handouts are publicly available. So those acupuncture handouts are up there. Yep. Did I say acupuncture, acupressure? Yeah, I think I said acupressure, but they're available.
Great. Thank you so much for your presentation, Dr.
Thank
Kadro.
you. Thanks. Thank you very much.
All right. Next up, it is my pleasure to introduce Barb Regis, who's a physician's assistant in our survivorship program. I think you're in for a treat. I've worked with Barb clinically over the last several months. Her talk is entitled Survivorship Care, Empowering You, My Fellow Melanoma Survivors and Caregivers. So, Barb.
Thank you. This is where I really get nervous with the clicker. Click on, click off. See if I'm pointing it right. Oh, okay. So I honor all of you melanoma survivors because today and this month is Melanoma Survivor Month. And, you know, it's all about support, advocating for yourselves, and cure. All right. I can use that. Okay. Does that work? Sorry. I like to run around the stage. I don't know why I get nervous, I guess. But today, what we're going to do is talk about a few things. My story, understanding survivorship, challenges that affect all of us, diving into distress reactions, living the day-to-day, Operation Thrive, and the survivorship consult visit. And we're going to do it in 12 minutes. Got this. There I am. I was diagnosed in 2018 in Phoenix, Arizona with amelanotic melanoma. I'm a provider, I'm a PA with 27 years experience who actually had a lot of patients with melanoma that I actually was able to diagnose, but mine was a little bit different. And I had a recurrence in 2020. I did IPI for a year, and then I did NIV for a year, then had my recurrence, and I did IPI-NIV. And I'll be honest with you, it almost killed me twice. And I made the conscientious decision after 3 rounds of therapy to stop. I was doing radiation at the same time because I was like, if this didn't beat it, nothing's going to beat it. So I'm here today. So I'm thrilled, just like all of you. So be excited about that. So a lot of times people say to me, what is survivorship? Am I a cancer survivor? Well, I want you to take a look at that definition right now. An individual considered a cancer survivor from the moment of diagnosis all the way through. But you know what? Not everybody feels like a survivor. I wanted to give you some statistics here, and then I'm not going to ask you to answer the question and raise your hands, but I want you to really think about it. Do you think you're a survivor or do you not? And look at this. This is an interview that was done last year, and 90% of those that completed treatment felt like they were survivors. But what really stuck out to me in this survey from the National Cancer Coalition was that 72% stage 4 felt like they were survivors. I think that's fantastic because you know what? A lot of us are living stage 4 and we're living for a very long time thanks to the amazing work of these physicians who spoke to us and their counterparts across the country. And for them, I'm eternally grateful. But here's the interesting thing. 30% of the patients are getting follow-up care from their primary care providers, only 30%. So one of my visions is I'm going to work on that. I'm working really hard to make sure that everybody that sees me has a primary care provider, and that primary care provider knows exactly what to do. Because I think as a primary care provider myself, the problem I had was, oh, they're seeing the oncologist, I don't have to worry about it. But no, you're still my patient. And so we're going to talk about that a little bit later. This is the best news. Check that out. Look at how many people are living. It's fantastic, isn't it? Look at 1975 and then prediction for, 2040, 26.1 million cancer survivors out there. So what are we going to do, right? We're all surviving cancer. We beat it or we're living with it, but what do we do next? So I'm not going to go through this whole slide due to time, but what really stuck out to me is like now because of immunotherapies, because of all these different treatments that are on the rise and how people are responding, 70% of melanoma patients are living 10 years. Now it's interesting. I had a conversation with Dr. Byrd a while back and he said, you know what? 10 years, 12 years ago, we hardly had any physicians going into this realm because nobody was living. But now look, we're living. And so that gives me hope. That's what gives me inspiration. That's why I'm here at Fred Hutch. Now, I want to make a difference. This is my giving back too. This is us, surviving and thriving. So one of the things that's been really interesting is patients have been saying to me, I don't like the word survival, Barb. I don't like it. I go, why? Because I'm doing more than surviving. I'm trying to figure out how to thrive. So a lot of people are saying, can we call it survivorship? I said, well, we'll go back to the parties at Frank Hutch and see if we can change it to survivorship clinic. All right, so let's get real for a second. Everybody knows, you get this diagnosis and we're getting all these amazing treatments and we're getting this great care, but man, there's a lot of stuff going on in here. It's all the psychosocial stuff, the stress, the quality of life, all of these different things are happening. And so sometimes we don't have time to talk about it, and sometimes we don't feel comfortable talking about it. This is all cancer survivors, not just melanoma, but this is a slide that I think is really interesting because it tells you, the physical concerns that these survivors have. And I think it takes, energy, concentration, sexual function, neuropathies, pain. And then I'm going to flip to emotional, the big one, fear of recurrence. I bet you if I asked an opinion on that, probably about at least 60 to 70% would be raising their hands right now. I know I would be. But look at that, grief and identity, appearance, family member sadness. What does it do to affect our relationships? Those who appear to be functioning well may have needs that are not observable. Again, it goes back to sometimes some of us just don't want to talk about it. We're not ready to talk about it. And we all have different times in our life where like, now I'm ready to dig in on the hard stuff. Distress reactions, uncertainty, grief, loss. What will my new norm be? And the fear of recurrence. Let's dive into that for a second. Now, I want you all to think this is you up here. Nobody has to share anything with anyone. This is a personal moment. But I think a lot of these questions probably relate to you. What's going to happen in the future? How am I going to deal with work and home responsibilities? How am I going to balance all this out? And then all of a sudden, for like me, for example, I have adrenal insufficiency now. I'm alive, but I take steroids every day. If I don't take them, I know what's going to happen. I also have salivary gland problems. So if I run to the mic, because I need water, that's why. And so it's changed things. My body image has changed. I used to be a long distance runner. Can you believe it? I had triathlete, and so I can't do that exactly, but I'm working on it. And then for me, a big thing was like my independence. And as you know, my family, I'm very stubborn. And I didn't want cancer to be what identified me. I was not going to let that happen. And that's a thing that when patients come and see me, they'll say, that's what I struggle with sometimes. Like it's become my new identity. I don't like it. And they go, well, let's talk about it. Let's work our way through that. Will I be thought of Barb as the cancer patient? Will I be able to adapt to my new challenges? Will I finally be able to accept my life as it is and embrace those challenges? And I have a hashtag I use all the time on social media. Are you living or existing? Fear of recurrence. How many people have skin anxiety and right before you go, the what if, 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 what if? So what I found for me is when I deal with what ifs, I just kind of try to come up with something that I'm grateful for. And a lot of times it's my family. I'm grateful for the care I've had. I'm grateful that I was able to walk down to the marketplace and back. Things like that. You know, the other thing is like taking the risk of like, how do I rebuild my life? So let's say you had to have a career change. How do I go forward? How do I figure these things out? But what if the guard's always up? And yeah, I mean, I don't care how many years out. When I talk to patients in the clinic and I see patients of all cancer types, it's always that last thing. I can't let my guard down. Right? So I had a revelation. One day I said to myself, every day I would ask myself, why me? And then one day I realized, why not me? At that moment, I knew I had to figure out how to live my best life knowing it would never be the same. And so the point on this is that I was taking care of everybody. I diagnosed a couple melanomas that were pretty rare back in the day. And, you know, I was the caregiver. I took care of everybody. I got you into oncology, I got you into dermatology, I got you into theologies. And then it was me. And I'll tell you, it was like crazy. But, you know, I had to work through that. And I knew it wasn't going to be the same. It's not going to be the same because I can tell you when I was diagnosed in 2018, if anyone ever told me I'd be living in Seattle now and I'd be working at Fred Hutch and consider cancer survivorship with that, what are you talking about? Life, you know, and this is the thing that is so gratifying to me. My cancer has taught me so much about life and so much about gratitude and so much about how you can move forward, but it's not going to be the same. But you know what? My new life isn't so bad. So again, what is it that we can control and what we can't control? So we're going to fly through this real quick. So of course, you know, we have our amazing surgeons, oncologists, all these therapies that are coming around. Can't control our age, I wish we could. Gender, sign of birth, and genetics, but we can control our social, other health issues, lifestyle. So this is something that, you know, you got to think about, like what lifestyle can I control? So we have all these amazing support services that you've heard from today, integrative nutrition, we've got cognitive behavioral, we've got it all at the Hutch. And that's what's so awesome about working here. And so the thing is, we can control our nutrition. So I refer all the time to our RDs, making sure that somebody gets an opinion or if they need a fresh look at things. Exercise, alcohol and substance abuse, you know, don't drink. Quit smoking. And then as Dr. Kadro said, you know, sleep is huge. Social, that's our new dog, Jules. She was out on the boat on Lake Union yesterday with our family. And don't isolate. You know, address it. You know, let those that want to help you, but it's okay to set boundaries. Because you got some people like they want to help to the point of no return, or their help is not productive. And so being able to figure that out, but let them in. Prioritize self-care. The most important thing is I say to my patients every single appointment, I go, what are you doing for yourself? You'd be surprised. People about 70 to 80% go, nothing. I'm like, can you just for 10 minutes a day, listen to your favorite music, take a walk, do something that's just for you, not about the family, getting the kids to school, not about, you know, appointments and stuff. What can you do for yourself? And for everybody, it looks different. For me, I like to do car karaoke. So I get in the car and I make sure my husband's not there because he don't want to karaoke. And I'm really into certain groups, but I have a good time with it. I don't know about the people next door because sometimes I take the sunroof down. I'm like, hey, I'm having a good time. It's fun, you know? Manage the stress the best you can. Figure it out. For me, it's car karaoke and my pet Jules. Now, here's the important thing too. besides all of this that we've talked about, it's really tuning in with your primary care provider about what they can do. Guess what? Oh, we get the melanoma diagnosis. That doesn't give us the passcode card about breast cancer, colon cancer, prostate cancer, and all those cancers out there, right? So it's really important that a primary care provider knows about what they need to do and understand our treatments too. So it's really important to get in for a physical exam. It's important to, address those chronic conditions like you're diabetic, let's say you have hypertension, all these kinds of things, because it's all kind of interconnected. So, we have, and everyone's here is like, so what do you do? Like, really? Okay, so here's what I work for the Survivorship Clinic, and basically, here's our mission. And what happens is that patients have discovered me. So in the old days, it was like, you have to get a treatment 5 years, 10 years, no, 15 years. We don't know how many years, but you have to be done with treatment. But now I've got patients actually in active treatment. One of my favorite patients just got done with had AML, had recurrences in his 80s. And he lived at the hutch for 6 months. And his wife came in to see me twice just for like recommendations, how to think about things in the process, all the psychological stuff. So basically what it is it's an appointment where people, anyone in the state of Washington, as long as you're in the state of Washington, you don't have to be a patient at Hutch, can actually be referred to our services. And then what we do is we do a deep dive into your records. So if you're treated at MD Anderson, Sloan Kettering, Pittsburgh, Pennsylvania, we'll get the records, we'll put everything together. And then what we do is we get you in for the appointment. And what we really can is this. How you doing today? Or how you holding up? And you'd be surprised the stuff that comes out. It's the one time that you can come in and really talk about how you're feeling. And so this leads to referrals to counseling. This leads to referrals to Dr. Kadro. This leads to referrals to these places. Plus, when they find out too, I'm a cancer patient, they get real, really fast. So what's really fun about these visits is that it's all about you. You get an hour with me. And then what we do is we get this component together and we figure out, and sometimes people don't want to talk about sex with me the first visit. I don't understand why. But second visit, when you plant the seeds or going to a counselor, they'll come back and they'll go, okay, you're all right. And then they'll tell you something. And then all of a sudden you go, well, we can take care of that. All I need to do is talk to your PCP and we'll talk about ED meds or whatever, or I'll get you a urologist. And they feel so empowered. And that's what survivorship is all about. Good news, it's covered by insurances. We check and make sure that your insurances cover it. The cool thing now is we're working with all different service lines to figure out how we can employ survivorship in the service lines. But that's not going to happen tomorrow or probably in 2 months or 6 months. What's going to happen down the road? So we're really excited about that. These are some of the things that our patients say. And the care plan is probably the thing that they love because then they go back to PCP. Because sometimes, like, for example, things like, the mammograms will be missing. And they'll go, well, I didn't have one for like the last 4 years. I'm like, well, you need to get a mammogram. So they go into the PCP and just give them gentle reminders. And I send these plans to the PCPs with very gentle reminders. And then the other things we talk about long-term effects and late effects. And we talk about how that affects things that we need to be looking for in the future. So like with certain chemotherapies, and as we talked with TIL therapy, this is going to apply with what Dr. Lee talked about. We have late effects with that particular chemotherapy. That's cardiac, for example. And so those are things we share with the PCP. Be watching for this. And we do additional studies. This is the most important slide. My prescription to you, gratitude. Take a dose in the morning. May it cause a shift in perspective. May it cause feelings of abundance. Decrease feelings of fear and anxiety. And one last thing is that we do have a survivorship conference on June 1st. There's some information on the table outside. We're going to have a lot of breakthrough sessions. So like Integrative, for example, a lot more detailed information, those kinds of things. We'll have all sorts of speakers plus a keynote speaker too. And the whole idea is that we all work together here, and it's an honor to be here today. Thank you.
We have a couple of minutes for questions.
Do you meet with caregivers?
Absolutely. Yeah, it's great because when we meet with the caregivers, a lot of times, especially their needs aren't being addressed. The needs aren't being addressed quite as much. So a lot of times it's really great. Yeah, so it's the patients and caregivers. And so, I alluded a little bit, I should have spent more time saying how, we're so grateful for our caregivers and everything they do for us. And yeah, we go through the stages of grief, and sometimes caregivers really need to have a little bit of help with that, and yeah.
I'm gonna say it because my husband died last March, so.
Sorry.
He died. And I was his caregiver, and I'm a big advocate, and Dr. Byrd knows, and Dr. Lee knows, but I had a man come up to me and said, I wish my wife could talk to you because she's his caregiver.
Right.
Caregiving, and when it's serious, it's hard. And I just want to say, please think more about what you can do for the caregivers.
And we absolutely are doing that. And so, yeah, I just had an appointment with a patient last week and finally, recognized the caregiver is like, okay, I'm ready for that counseling referral. And sometimes I think the problem is that people realize that it's hard to find referrals to good resources, but we're developing a lot of really good resources inside and outside the hutch to get people into the right services quickly.
But it's not always an outside resource. It's what you can do, and just having somebody to talk to. Sometimes maybe even having, like, when they had just a forum or something, just so people can kind of lay it out there. Because when you read things and you go, oh, I'm not alone, somebody else is feeling the same way. So it's not always like a professional, but just like a community.
Yeah, and what you may want to do, and I don't know if you've searched it yet, is check out Cancer Lifeline.
Yeah.
But no, I think they have some caregiver resources as well.
Hey, I'm good.
Okay.
I'm good. I'm talking about people who are now caregivers. So I'm
Yep.
gonna be quiet, but just that's what that's kind of my advocacy.
Yeah. And I assure you, caregivers are welcome. And what happens a lot of times, I said, finally they'll start opening up, and it gives a chance for our patients to be able to share some things with the caregivers that they haven't been able to share before. So I hear you. I hear you.
Thank you, Barb. You can tell we've already started patient stories because Barb started her story. I wanted to just give a little preamble before the story givers, and Dr. Hall is going to introduce the storytellers. To me, the most meaningful part of life is stories. It's our stories. These are cancer stories, but it's our stories. If you look back into the evolution, I'm reading a book called Sapiens right now. I don't know if you know that book, but the development when humans became humans is when we became able to share stories, and other species were not able to do that. And not only is it a valuable way to communicate, but it's a valuable way to reach the hearts of other people and be heard by everyone. So I'm a huge believer in stories. We've started this from the beginning. We did this the very first Melanoma Symposium. I told you about Katie Bunker's story. Amazingly, somebody did follow her, although they shouldn't have had to. So there's almost a sacred reverence for this time of the symposium. That's why we have it at the end. And I want to thank our two storytellers today and those who have told their story before. We have several in the audience who are past storytellers. It takes courage to stand up here and tell your story and to open up. And almost uniformly, I've had patient storytellers say, I don't really think it's very interesting. And the audience is really not going to get that much out of it. It's exactly the opposite every time. So thank the ones from today. And I mentioned if those of you who want to think about this in subsequent years, come up to us afterwards and let us know. I just wanted to start off with that and let Dr. Hall take it.
I share Dr. Byrd's feeling this is the best, most kind of impactful part of the program. And with that, I'd like to introduce our first story. Ann Blicky, who happened to be one of my very first patients when I set foot on this campus. So Ann, take it away.
Good afternoon. I just practiced my 4-4-8 breathing up there, so I really appreciated that new tool. In my life, when things have become difficult, I've had this image come into my head of me being deep in the water after diving off a swim block and kicking hard with everything I had in me to get to the surface and come up for air. I was asked to speak because we have something in common. Whether you were diagnosed with and found out about cancer at stage 1, 2, 3, or 4, I share that experience with you today. In less than 1 year, I watched cancer progress from stage 1 to stage 4. It left me gasping for air. As many of this room know, hearing the word cancer quite simply takes your breath away. Today, I'll share my story over the last 5 years where I felt underwater and my efforts to which led to coming up for air. To be authentic to my story and to paint the entire picture, I'll start from the beginning. I got into a routine of getting my moles checked in my early 20s. I acknowledged that I was prone to skin cancer with summer swim team sun exposure as seen in this picture, lifeguarding, tanning beds in high school, and long days of sun exposure backpacking in my 20s. I have fair skin, light eyes, yet I tan really well, which is a dangerous combination. At a routine skin check, November 2018, I pointed out a spot on my left shoulder, which I saw for the first time. I was told it was fine. I questioned it was fine. Then I believed it was fine. 3 months later, it caught my attention again. It was in a tough spot to see my shoulder. I got a second opinion, and on March 4th, 2019, the results came back with a rare type of melanoma called amelanoma melanoma. I was in disbelief. 1 month later, I was scheduled for surgery. Radioactive dye determined which lymph node to biopsy to see if melanoma had spread. That was a stark realization that this cancer was worse than injecting my 39-year-old otherwise healthy body with radioactivity. The melanoma mole was removed, resulting in a 4-inch scar on my left shoulder and had a sentinel lymph node study. This surgery was days before my daughter Gracie's 6th birthday. My son Benjamin was 3.5 years old. My lymph nodes came back positive, which meant the melanoma had spread to my lymph system. The melanoma came back as having a very fast mitotic rate and was referred to as aggressive. My care team acted quickly, and with my first line of treatment was immunotherapy infusions in the adjuvant setting, which began just weeks later. During this first 12-week cycle prior to the scan, I learned I was BRAF positive. We were all around optimistic, feeling like this was a scare, yet we felt like we had the precautions in place to manage this situation. My scans later that month detected that immunotherapy did not work, as the melanoma had unfortunately spread and multiple tumors were detected in my left armpit lymph nodes. It was decided I would need a full lymph node dissection surgery and needed one soon and a second line of treatment. Over a month later, at a 7-hour surgery where Dr. Kim removed all my left armpit lymph nodes with some neighboring soft tissue, which was observed during surgery to be also impacted by the melanoma. In addition, at a left arm lympho procedure, this was a procedure that connected my lymph system into my bloodstream with the goal of reducing my risks of lymphedema. I remember thinking this elective portion of the surgery was an optimistic view for my outcome. As we knew, with immunotherapy having already failed, I was underwater. I was put in touch with the Fred Hutch medical researchers where my tissue donations went after surgery. I wanted to be an active part of understanding my situation and attempt to be an active part of the solution. Weeks later, I started one of the targeted therapy treatments of chemo pills. I had extreme side effects of big chills and high fever episodes called rigors. My husband, Mike, would lay on top of my convulsing body from chills when I was covered with blankets to get my body to stop shaking. I would eventually spike a high fever and throw up. These episodes occurred often. I thought these were signs that I was on track and well on my way to harnessing control of what was now a metastatic disease. I went to the hospital multiple times in the first few weeks and would not be here today if I had not kept showing up. September 16th, 2019, I went to emergency for the third day in a row, sharing my unusual and many symptoms of really not feeling well. By deep gratitude to the attending doctor that night, I was admitted to UW's oncology ICU unit. Had I not been admitted, I was told I would have not made it through the night. I experienced septic shock and multi-organ failure. My family came to visit me to say goodbye. I acknowledge the luck that is woven through my story and how fortunate I was to have survived. Dr. Hall, new in my case, came to visit me in the ICU. After the first week in ICU, I was transferred to the general hospital without being able to walk and neuropathy in my legs. With daily supportive PT and OT, I was able to leave a week later with the assistance of a walker. After this near fatal event, it was determined I needed to remain unmedicated because my body needed to heal from the septic shock and multi-organ failure event. My body and organs sustained significant assault, and I have proof after this acute event that our bodies can heal. Not being medicated was a devastating reality. We were consulting with multiple oncologists at this point. I felt like I was sinking. During this unmedicated time of healing from septic shock and multi-organ failure, I dedicated myself to dilute my thinking to gratitude as I was fighting for my life to get through the days. I found this to be as much of a mental and spiritual journey as it was a physical one. I engaged in weekly acupuncture, Reiki energy work, therapy, meditation, aimed for clean eating, prayer, walks in nature as much as my body allowed. I was gasping for air as my future was unknown. The results of my next scan showed evidence that the metastatic melanoma cancer spread from my lymph system and into my bloodstream, as there was suspicion of disease in my spleen. This is an unusual first metastasis. I had a spleen biopsy, not a common procedure. We got a call from Dr. Hall on New Year's Eve, hours before 2020, that my spleen was positive for melanoma cancer. Given that this disease was now in the blood system, there's need for a new systemic approach. As you can imagine, this was a devastating development. I remember sharing with my family, you hear people beating stage 4 cancer, and I want that to be me. Gracie was almost 6.5 years old at this point, and Benjamin had just turned 4. I was desperate to live long enough for my children to remember me. There are no pictures that can describe this time for us. We realized my outlook was dire, the immunotherapy had failed, and the targeted therapy chemo created an unheard of adverse response. The decision was made to try the combination immunotherapy infusions. This was the remaining FDA-approved treatment option. This is when I decided while in treatment, it is always important to know what the next line of treatment should be if this fails too. We created a plan. With thanks and grace to Dr. Hall and our countless conversations, we determined if this failed, I'd go to MD Anderson in Houston to research the teleclinical trial. I also actively pursued alternative therapies in the Seattle area as I knew this was my last chance. I need someone to throw me a life ring. In January 2020, my body very quickly had a very high toxic response to the combination of immunotherapy infusions. We needed that backup plan. The combo immunotherapy woke my immune system, the goal of immunotherapy to activate the immune system, identify and attack the cancer. The unfortunate news is that it attacked my liver and again, not the cancer. So I quickly had to medicate with high-dose steroids to tamper my immune system. I was once again off the cancer treatment and was drowning from not being able to control and fight this cancer. During one of multiple emergency visits from being so sick, the scans showed a swelling of cancer growth in my spleen. Additional scans were taken 2.5 weeks later, and these scans showed that my aggressive cancer had commanded a new presence and had spread from my spleen to both my liver and lungs. A neighbor friend who had prayed for me and had the idea of connecting with our church of our family's faith tradition. She orchestrated a sacrament of healing, which is the anointing of the sick. This felt meaningful and profound. I took this on to embody a deep strength. It made me feel not alone, and it connected me with my inner fire for healing. To say our trip to MD Anderson was pivotal for my healthcare is an understatement. Mike and I met with Dr. Diab, an expert in melanoma and immunology, with the intent to better understand the teleclinical trial and get another review of my case. While there, I remember being asked if I too was a doctor. I had taken on my case as if I were one. We were captivated by Dr. Diab's assessment of my pathway should be to move forward with our shared objective, harnessing control of this cancer. Modern medicine generally says the metastatic cancer at stage 4 can no longer have a curative intent. The goal is life extension, not Dr. Diab. He gave us that day, what he gave us that day was hope. He determined my cancer was growing too fast for the teleclinical trial. There was just not time. There was a second brand of targeted therapy chemo treatment available, and he had a theory. When pulsing the targeted therapy with immunotherapy, the targeted therapy would flip the switch on the BRAF mutation, stopping the repel of the immune system and giving the immunotherapy a chance to work. He knew that immunotherapy had failed 2 times already. We did not think going back on targeted therapy chemo treatment was even an option given my near fatal experience in the fall. I had no choice. This was my only option. He spoke about fear and that fear cannot get in the way of hope. And there was hope we collectively had for me to overcome this aggressive disease. And so February 2020, almost a year after my initial melanoma diagnosis, I engaged my fourth line of treatment back at Fred Hutch under Dr. Hall's care of a targeted therapy and immunotherapy. At this time, I was very aware the odds were against me. I did not let myself prepare to die. I rolled the dice with my actions. I did not make my baby books and say formal goodbyes. I did what I needed to do to fight to live. Instead, I wrote notes to my kids inside the book, The Invisible String. I wrote a card to my husband and shared with my best friend, my mom, wishes for my funeral, and left a paper with my funeral plans tucked inside my bedside table. I wrote Post-it notes with messages around our house, and I said Alexa to wake my family to All You Need Is Love by the Beatles. With close monitoring, this new targeted therapy was working to flip the switch with the BRAF mutation without significant side adverse reactions. And I was waiting to see, with the pulse off the targeted therapy, if the immunotherapy on its own could activate my immune system to identify, control, and fight the cancer. I knew there was still no way to tell what my future would hold, and I would be living scan to scan for the new future while continuing with every other week immunotherapy infusions. I spent every ounce of my being fighting to live, maintaining focus on healing. I had two goals during this time: fighting for my life and building community for my children. Community has long been a core value, and I knew this was going to be the core of support for my husband and children in the case I was not here. COVID clearly created obstacles with the goal of building community, so I rented an event tent and did just that. The kids social distanced while painting pumpkins, made gingerbread houses, and it gave us a place to live amongst community in the present. We saw angels emerge in our lives. During this time, I became deeply infatuated with what it meant to be human. I had lived a holistic and integrative lifestyle prior to cancer, and I was even more invested in understanding how this human experience worked and how I was going to heal. I connected with astrologists, mediums, Reiki and energy practitioners, a variety of physical therapists, read books on meditation, and Zoomed with practitioners from overseas. I did this while we were keeping the vibrations positive in our household, and we would be found having dance parties to Macklemore. I focused on hope and gratitude every single day. 2 alternative treatments became constant for me in addition to immunotherapy infusions. I went to acupuncture every week. I believe this helped my body process the toxicity of the treatments and allowed my treatments to work well beyond the typical treatment capabilities. My acupuncturist, Annie, became more like a health coach, reinforcing my path, my progress, and giving me faith in my healing potential. While there, I envisioned a massive boat in the ocean, more like a barge, and with the turn of the wheel, the course of my health, yet slow and steady, completely changed trajectory. I had weekly Reiki acupuncture appointments with a Reiki practitioner who also is a psychotherapist, Sharon. Part of our sessions were recorded, and there were positive messages of my immune system fighting, my immune system winning. I would listen to these recordings multiple times a week while walking to the street to the lookout in Madrona. In reflection, I wonder if I would be alive without this constant reinforcement of hope, mindset, and believing in the power of myself, and that there was a human capacity to heal. The COVID quarantine allowed for the time to quiet the distraction and to develop my intuition. I felt connected to being a spiritual being in the human body, and that our entire reason for being here was to learn. After about 6 months starting the 4th line of treatment with a pulse on of the targeted therapy, on of immunotherapy, off of the targeted therapy, scan results indicated no new cancer growth and cancer regression from the immunotherapy on its own. This felt huge. With this stability, I continued to focus on healing. Dr. Hall, Andrea Purdue, and Julia Majowski continue to be close partners in my care. I showed up weekly with a page full of questions, and they would patiently answer all of them. I gave Dr. Hall the book, Radical Remission, Surviving Cancer Against All Odds by Kelly A. Turner, PhD. I asked him to please read so we could discuss. He was not aware of this book, and I wanted to hear his thoughts on the impacts of alternative thinking outside of modern medicine. After a conversation, he agreed to what I surmised as an ongoing theme in the book, the one that I felt validated my approach. A patient feeling empowered to be able to influence their own healing really does make a difference. One night while reading a book to my children about puppies, I saw a picture of a St. Bernard puppy. An overwhelming emotional reaction occurred. I'd always loved St. Bernards, and I even attempted to adopt one in my early 20s, and my husband and I were only newly dating. This deep emotion led me to believe that was a sign. Yes, we needed our first dog, a St. Bernard puppy. And on January 4th, 2021, Augie came into our lives. I thought there's no better way to focus on hope and healing than with the life energy of this little, soon to be very big puppy. I wanted to know Mike, Gracie, and Benjamin had a heart-filled and protective companion who would be there to support if I wasn't. Turns out I was the one who really benefited from Augie's presence. We did not rescue Augie. He came at just the right time to rescue us. I lived with the status stable and maintained immunotherapy infusions. During this entire time, I never let myself fully breathe, as the reality was this was far from behind me, still undergoing active treatment. I was successfully controlling the cancer with treatment, but the treatment side effects accumulating. I needed a plan. I took the March 2022 milestone of 2 years without cancer growth as a great accomplishment. The cancer had slowly and greatly regressed as well. I was told this was statistically significant, as it was less likely for cancer to grow after 2 years' time. I started to think of my plan to reduce treatment as side effects started to feel important to consider. In consulting with Dr. Tachiki, I started a gradual reduction of immunotherapy infusions to titrate the treatment. I've been off immunotherapy for 1.5 years now. And during break, Dr. Tachiki told me that research showed that the immunotherapy stayed in my system for 8 months' time after treatment. I've had close surveillance over the last 5 years with 3 to 4 month interval scans up until this past January. You now find me in my first set of scans that are 6 months apart. There is no medical way to know for sure what is showing up on my scans. Are there spots remaining, a live cancer being controlled and surrounded by T cells, scar tissue, and/or burned out spots? My medical team has conducted ongoing circulating tumor DNA blood tests, which have yielded good results, reinforcing positivity for my progress. I must believe that what remains of this cancer is from this experience is scar tissue. It makes sense that I emerge from scars, as this experience and the lessons learned through it will remain with me forever. Over the years, I've been asked to connect with friends, friends of friends, friends' husbands, parents, colleagues about my experience with cancer. I developed a mental model that I shared with others. I spoke about the feeling of hearing you have cancer, and our society puts modern medicine in the center of our wheel for healing, and we're hanging on to the handle of the wheel, hanging on tightly, falling into a victim mindset, barely having feet on the ground, and just hoping it works. My mental model is about putting yourself in the center of your healing. We're in the middle. When you're in the middle, we can pull from the modern medicine as one of the handles. It hasn't been until now that I've worked to put my mental model onto paper. This graphic depicts my story and my having agency in my ability to heal and pulling on each handle at different times to help steer us in the right direction. I can say speaking with you today is giving me an opportunity to reflect on what I've been through and take a deep breath. I've come up for air. I've learned the most important relationship is the one you have with yourself. Self-advocacy can save your life. If you're not sick, that's the best time to heal. Healing can occur physically, but also mentally, emotionally, and spiritually. And engaging in all those aspects can continue to be more positive results. Food can heal, sleep is essential, and stress depletes our immune systems. There's a strong mind-body connection, and I believe in focusing on healing versus fighting for my life benefited me. The intuition is real. Our bodies are trying to speak to us. We just need to avoid the American culture of distraction and be present enough to listen to it. It is important to be conscious because where we spend our energy, intended or not, creates outcomes for our lives. We need to be empowered to know that we can heal ourselves, and we cannot rely on others to do that. Community is essential, and to be a thriving human being, I have learned that cancer is a trauma for patients and caretakers. I'd like to thank my caretaker, my husband, Mike, who is here today. I believe emotions are things that we give each other. Today, I am giving you the emotion of hope. Hope through the process of diagnosis, hope through treatment, and hope through your recovery. I am grateful. I am most grateful for the medical advances in melanoma and all the researchers and doctors who have dedicated themselves to this challenging cancer. I am living proof of the power of your collective perseverance. Immunotherapy and targeted therapy were FDA approved less than 10 years from when I started them. I feel like I'm living on the front lines of modern medicine, thanks to all of you. I'm grateful for Fred Hutch and the incredible team members who I've worked with over the last 5 years, a place where people come from all over the world for expert partners in care. And extra thanks to Dr. Hall for having the same goal for me as I did, to live, and the opportunity to speak today. My goal never wavered of being here for my children. Gracie's now 11, Benjamin's 8.5. 5 years later, they've seen what it looks like to kick hard, struggle to breathe, come up for air. They've seen the pain and in the progress have learned how to swim. Augie, now 3.5, has not only helped me and our family, he's also now a comfort dog at a local high school and helping others. I had a fire to live and is now within me to help others with cancer. I am enrolled in the Radical Remission Cancer Coaching Program, and I hope I can dedicate my story to helping others and to do so in honor of those who are not as fortunate with cancer and to be with us in community today. Thank you.
Thank you, Anne. I'd like to introduce our second patient story, Mr. Churgai.
My name is Churgai. It's actually pronounced Maria. It is Norwegian. Don't worry, I'm taking pills for it. My father was Norwegian too, and he died of melanoma. My grandma had melanoma. I've got cousins and uncles and aunts, and there's a lot of melanoma everywhere, so that's why we're all taking pills for it. And actually, it's kind of, I found out that it's pretty prominent in Norway, in most of Scandinavia. And so my journey with cancer started long before I actually had cancer. My dad, he got melanoma in the early 90s. And at that time, it was a death threat. I mean, it was, you know, you're toast. And they said, oh, you've got a few months to live. My dad, funniest guy you've ever met. Always positive. Just, you know, he's so much joy with him. And that's how he lived his life. That's how he lived and faced his melanoma. A decade later, he finally passed. And his doctors were like, this is very unusual to survive that long with melanoma all the way through. I mean, he had melanoma everywhere in his body. He survived 10 years. And my wife, she was 38. I was a high school principal and she was a CPA, and we have 2 kids, 5 and 7, and everything was going just fine. And then breast cancer came. And it was a very aggressive breast cancer. And they said to her, you know, you may not survive the year. It was already spread throughout your body. And this was, again, in the 90s. And so there wasn't immunotherapy. There wasn't a lot of things available for her. But she got treatment. And when she got cancer, she had only one prayer. I pray to live long enough to see my children get adults. 5 and 7. How could that be? She came very, very positive, full of joy, full of love. Not once did she say, why me? And she even said, this breast cancer has been one of the best blessings in my life. Like I said, well, why? And she says, oh, easy. I told both my sisters to go get checked. They both have breast cancer. And it was detected very early, and they're going to survive. And she switched jobs, being a real pressure cooker to being in a job that had the same schedule as me. I left the principal's office and went right back to the classroom, and I had the same schedule as my kids for 10 years. I mean, she was supposed to die that year, but 10 years of time, we all had the same schedule. We traveled all around the world, did all sorts of amazing things as a family. 1 week after my youngest daughter turned 18, cancer came back. It's like 1 week. She said, if I would have known God was a CPA, I would have did a different prayer. So she had a second prayer. Dear Lord, what I meant by adult is graduates from university, having a degree and being able to be self-sufficient. She passed the day after my youngest daughter was pinned with a nurse and had a job at a Swedish hospital. But you know what she did? Never once did she say, oh, I can't do this. Oh my, that's terrible. Everything's bad. No. Every time she would say, okay, what can I still do? Example, this is like a couple months before she passed away. She was in bed. The nurse practitioner or the hospice nurse, she was on hospice for over a year. That's a long time. So hospice nurse said, you no longer will be able to walk. We used to get this long walk around the lake and did this, and it got shorter and shorter and shorter. Finally, the big walk was to go from the bed to the bathroom. And suddenly she couldn't even do that. She's not going to get out of bed ever again. She goes, oh, can I still go in a wheelchair? She said, well, of course. She goes, hot diggity dog, let's go around Yellow Lake. We got there, put her in the wheelchair, took her to the car. We went around Yellow Lake, which we used to do all the time. And she was just so happy. Like, wow, this is great. It's like, it's great. You never will be able to stand on your own 2 feet again. But no, we can do these things. We'd send both our daughters off to coffee, and they came home, and the car's gone, and mom's gone, and dad's gone. We didn't even know. Luckily, there's cell phones. But that's the shoulders I'm standing on when I'm starting my cancer journey. Be positive, be focused, be with your family, humor. I have a couple examples of ones I don't want to follow. My mom had pancreatic cancer. They said, oh, you have 3 months left. Of course, she went to the very, very, very best source she could, the internet, and found out that you do coffee enemas 5 times a day and only drink the juice of green apples and organic carrots, and you'll cure pancreatic cancer. She did that, and a week later, she was dead. My sister, ovarian cancer. Oh, you have, months left. But her husband, of course, went on the internet, got the real cure for ovarian cancer, got some really special pills from some guy that worked from someplace. She took them, and the next day she was dead. So I know what not to do, and I know what to do. So my journey started in the fall of 2020. They found a melanoma with a quarter on top of my head. They took it away and they said, oh, we got all the margins. A month or two later, I started having pain in my abdomen. Went to the ER a couple times. The first time, oh, you got stomach issues. Second time, it's your heart. I mean, they did an angiogram on me. They said, wow, you got a really nice clean heart. Thank you, but that doesn't answer the pain in my abdomen. We went down to Arizona. I was down in Yuma, Arizona, down in the ER again. Looked at it and said, it's definitely your stomach. I said, no, we've been down that route. So went back again, ER. And luckily there was a retired physician who was in there just to keep their fingers in the profession, retired. And she says, well, where's your CT scans? I said, they never known I did that. She rushed me down to the CT or to the scan, come back in my room, had the news on, and they're storming the Capitol, the news. I'm watching it's January 6th. I'm sitting there looking at it going, gosh, the democracy is going to be destroyed and everything. And the nurse comes, or the doctor comes in and he looks up there and he goes, wow, I got some really bad news for you. I said, I know, we're going to lose our democracy. No, you have cancer. You've got 3 tumors in your liver. One's the size of a tennis ball, and the smallest one is the size of a plum. About half your liver. Oh my gosh. January 6th. And she said, you get back to Seattle right away. So instantly flew up here, went to my care providers here, and she had burned me a CD of the scan showing all the tumors. Came up here, gave it to my doctors. They looked at it. The oncologist came back and says, no, it's not cancer. You spent so much time over in Africa that this is a parasite that you have. These are parasite clusters. And if we poke the parasite cluster, you have 30 minutes to live. This is very toxic. You're dead. You'll die. Oh my gosh. That went on for 3 weeks, trying to chase some stupid little parasites that didn't exist. Like I was saying, but I have melanoma. I have no. So finally, the very end of February, this is the last week of February. Now, I turned 65 in March of that year. So I was going, okay, Medicare is coming in March 1st. Oh boy. I get a phone call from my oncologist, which I've never met before. And she said with a very heavy Russian accent, she says, well, you have cancer. There's nothing we can do. You're going to die. You only have a little time. I think you'll die in April. You'll die in April. I'm sitting there going, wow. My daughter's sitting right next to me. Now she's a doctor, nurse practitioner. She's a primary care provider here at UW Medical Center, and she's listening on the speakerphone, looking at me going, bedside manners. But and she hung up. The phone call was a minute and a half long. And then she said, get your affairs in order, you're dying. You'll die in April. Now, here's the detail. You have to watch the fine print on everything. She didn't say what year. And I caught her on it. Boy, was she pissed. Boy, was she pissed. Every April, I've been really careful. I just got through in April here. So I go down, I go up to the oncology department where I was at and, being treated, supposedly. And I come into the receptionist, there's 2 of them. And I said, I need to get I need to see an oncologist right away to get this form signed so I can get all of my information transferred over to get a second opinion. But I said, well, the next available appointment is going to be in May. I said, no, I'm supposed to die in April. Well, do you want the appointment or not? And I said, no, I need just a minute to get it signed, and then I can go on with my stuff. Just no. She goes, our oncologists are very, very busy and very, very competent. So I said, well, give me a damn one that's not doing anything. It's incompetent. I don't care. I just need to see one of them. And the lady right next to me, there's 2 receptionists. She goes, what about Montgomery? And he goes, Montgomery? Montgomery? I go, who's Montgomery? And he goes, he's the one who doesn't do anything. He doesn't see any patients at all. I said, where do I find him? Down the hall, 3rd door on the left. Nobody ever comes in. I'm down the hall. I'm feeling, I'm not very healthy at this point. But I'm down the hall going, no, here's, come in, open the door. I felt like the Matrix. It's dark. He's got a whole 5 screens here with skeleton or numbers stuff. And there's a guy in there. He goes, can I help you? I go, are you Dr. Montgomery? He goes, yeah, come in. I don't usually see patients. I go, hi, that's what I heard. I sat down. He goes, tell me your name and your numbers. And poop, all my information's up there. I'm like, wow, that was fast. So I started telling my story about this. And he's going, as I'm telling you, he's going, oh, what did they do? Oh, no, what? Oh my gosh, look at this. And it was, I'd forced them to do a DNA sequencing because I wanted to know what type of cancer it was. And they did that, which is great. And then he goes, well, what do you need? And I go, I need an oncologist here at this place to find the paper so I can transfer my information and we'll get a second opinion. He goes, oh, Dr. Montgomery. Yeah. And they had the name of that hospital, which I'm not going to say. And so he signed the paper and he goes, he goes, what are you doing now? And I go, I'm going to go to Fred Hutch. He goes, Dr. Montgomery, Fred Hutch. He goes, I'm here just to double check on the people over here. I'm like, wow. And he goes, can I call somebody? And I said, sure. And he goes, hey, Evan, we got somebody for you. I said, and he goes, let me shoot this over. And he goes, all my information on it. And he's, Evan's on there, Dr. Hall's on the other side. And they're sitting there talking and you know, they start using this medical stuff, which I don't quite understand. But anyways, and he's asking these questions and he goes, you know, I think we can work with you. Wow. This was Friday, like at the end of the day, and everyone's getting ready to go home. And he goes, I really can't see doing it. I've got something I'm doing this with my family this weekend, but on Monday, I'm gonna have my staff work on this. Can I see you first thing in the morning on Tuesday? Yeah. Boom, I went there on Tuesday. Immediately went into UW Medical. They came in and gave me 2 different immunotherapies. And there was some marker in my DNA, which he could work with. And he used that to be able to create a chemotherapy and an immunotherapy and everything else. And I was going downhill fast. I was going downhill really fast. That immunotherapy knocked me in my butt. By the second, third day of being there, I couldn't eat, I couldn't drink, I couldn't get out of bed. I was laying on my side. I could whisper about 3 words, and then I'd have to get my energy back. Dr. Alex was the oncologist at UW Medical, and she was great. It was Friday, and she came in and she said to me, she said, you're the most positive patient I think I've ever had. You've just been such a joy and everything. And I could tell it was a goodbye because I may not be able to survive that week. I mean, I was starting going to a little bit of organ shutdown. My daughter came in and kind of confirmed all this. She says, Dad, you're really going down fast, you know. And she left, and then Dr. Palko comes bouncing in. He goes, I got it. I got these from Germany. And I went, what? And he got this, I got some pills from Germany, and you know, and so I took them. You know, I prayed about it and beforehand, and very clear message. You know, everyone's asking for a miracle. Go for it. So I did, and zonked out. Next morning, I hadn't eaten or drink for 3 days. Next morning, I wake up, and I see a full glass of water. And I reach over and I'm seeing my hand. I'm going like, wait a minute, my hand doesn't do this. Grab the water, guzzle the whole glass. The nurse comes in and goes, what are you doing? What are you doing? And I said, what do you got for breakfast? I'm hungry. I'm speaking in full sentences. And I'm like, this is really weird. And next thing you know, I'm getting better and better. And by Sunday, I went home. My daughter's this caregiver. And so I went home and to her house and it was great. I was doing immunotherapy and the pills and the whole sequence. It was not easy. I'd go through just violent shakes, and then I'd go into high fever, and then I'd go these awful sweats, and then back to high fever and shakes, sweats, and it's just continuous time. They even bought my daughter bought this huge blanket to wrap me in to soak up all the sweat every time. But I didn't. I'm sorry, Dr. Paul. I did get a second opinion, and I hired a private nurse. Do you have the picture? Anyways, very, very competent. You were great, but she was better. I mean, she really gave me what I needed. No, seriously, I mean, I just want to be honest with you. But anyways, so
Oh, it won't let me open it.
let's see. And she was great. She actually charges a little less than you did. She liked to be eating granola bars, and there she is. Okay, so during all this entire time, for the whole month that it was just such a hell month for me, she was my primary nurse. My blood pressure would be smiley face and my temperature would be 2. And but she had my daughter set this little clock thing for pills, when to do it and things like that. She would actually keep records of when I would be taking the pills and if I needed water or something like that. And she had a little marker for all these different things, just everything was going on. And I had a whole case of granola bars. So that was her pay. And she must be a doctor. So yeah. I came back to get every 2 weeks doing immunotherapy and everything. And after about a month and a half, Dr. Al goes, wow, look at this. Look at these numbers. Of course, they don't mean anything. Here's the chart. I'm like, uh-oh. I'm a teacher. When we see the chart going down, that's not a good thing. And he goes, no, that's your cancer numbers. I'm like, it's going down fast. And I'm like, oh, great. So, and it went fine, except the pills, after a while, I started losing feeling in my feet. And I came in and the nurse who was there came in and I had mentioned that I was losing my feeling in my feet and it could be the pills. And I come walking in and I have hearing aids, right? But this time I forgot to put them in. So I went there and I was about halfway there. I go, oh, I don't have hearing aids. So I come in and the nurse comes in and she goes, so I hear you're having a problem with Uncle Benny. And I'm like, Uncle Benny? And I said, I don't know who Uncle Benny is. And she had this blank stare and looking at me like, oh, it must have gone to your brain, And so she looks at me and goes, we started talking, and after a while, I realized that I was hearing Uncle Benny, but that was actually the name of the pills. So, anyways, I got those changed around, and the other thing, I got most of my feeling back. I still have a little bit missing, but it's okay, small price. And it kept on shrinking, the tumor, and then after about 2 months or whatever, he goes, look at this. He goes, your liver's growing back. And it's like, wow, this is really great. And he goes, it's growing back fast. My tumor was shrinking fast, and my liver was growing fast. And of course, this is the reason. Joy, fun, family, connections, something to live for. And what you guys do too, but you gotta have that joy and fun. Anyways, after 3 months, this is like summer's coming. I'm feeling great. I've come down and staying there with my daughter, Liz Quentin, and her husband and kids. And so it was hot. So I put on some basketball shorts that he had because I didn't have any shorts. And I had sandals, I had a baseball cap, and I had my sunglasses on, a mask because it's COVID time. And I'm sitting there talking to Dr. Hall, and he goes, oh, Dr. Alex is here from UW. Remember her? I go, yeah. And he says, go down and say hi. Popping down the hall, and I come, hey, Dr. Alex, how you doing? She goes, hi, who are you? And you go, John Ryan, remember me? I have never seen anybody turn totally white. I mean, her face was white. And her jaw dropped, and she looked at me and went, because back at the UW and that Friday to say goodbye to me. Monday, she came back and the bed was empty. She knew I died. So she's sitting going, you know, and Dr. Hall's right behind me going, rattling off a bunch of letters and a bunch of numbers. Every time he'd say a bunch of them, her jaw would got more. And then, you know, I'm just sitting there going, you know. And I thought, oh, okay. So, all right. So she's kind of, you know, she was in shock, I think. Well, the next time I came, these guys were all up on vacation. They like to do that, right? But the whole team was off. And so there was a new lady in there I had never met before, a nurse practitioner or PA or something. And so I come in and sit down and she goes, oh, I know. And she goes, oh, you're the Lazarus patient. And I go, what? She goes, oh, what? I shouldn't be saying that. I said, well, what are you talking about? She goes, well, that's what they call you here, the Lazarus patient. Well, Lazarus, he's going, no, he died, and 3 days later, Jesus came and rose him from the dead. So I was like, I'll take that, mate. You can call me that anytime you want, you know? And, you know, and I think that was probably from Dr. Alex, her experience of seeing me. So it just kept on getting better and better. And my numbers kept on dropping. And then after about a year, there was no sign of cancer in me. And so I've been on Nivolumab. And now I'm on the kind of the long-term one every 3 months. And we talked about whether or not I should stop or should I actually do every 3 months. And for this year, we decided to stick with the one every 3 months. We'll revisit every year. And so I definitely want to thank my nurse and you guys too for just surviving. A couple last things. One, keep joy in your life. Don't focus all the time on the damn cancer. If you focus on it all the time, you're living for the cancer. Don't do that. Live for joy. Live for love. Live for fun, connections, family. Live for something. And that'll help you along. And the other thing that I've learned by this is faith, science, not in competition with each other, and they're not against each other. They work hand in hand. And whatever faith you have, whatever beliefs you have, that with the science is an amazing combination. Much stronger than just one without the other. And that's my story, and I'm sticking with it.
Wow, I can't remember the last time I cried and laughed within half an hour as much as I just did. So thank you to both of our patient stories. I want to clarify so that pills that we got for Chell are FDA approved. They're the company that makes them may have started in Germany, but they're standard. There's nothing. I'll just clarify that.
So you can see why we like patient stories. Oh, feel like we've just been through this wonderful ringer. So thank you for coming. We are the co-directors of this. This will be my last one because I'm retired. I have been promised that I can attend. I may have to register, but I can attend. And I might just attend for the next few times, but thank you all for coming, and you got a couple quick comments and then we'll get people on their way.
Yeah. So David skillfully snuck in there. I was going to say something a little more about him, but I think I would like to thank everyone who's attended today's symposium, to the in-person and online attendees. This is for you. I think this is what started the spirit of community sharing support. This is what led the symposium to start and how it's going to continue year after year. I'd like to thank, huge thanks to Ritu. This does not happen without her. So we provide some guidance. She really takes care of most of it, and really it's a successful event because of her. So thank you to that. Thank you to our speakers who gave a number of wonderful talks about a variety of topics. Breadth is really important to what we try to go for this. And thanks to all of you attendees. I would also can't just let David say that. I came on to co-chair this event a few years ago, his invitation. It's one of the highlights of my year, and I'm honored to keep it going after he retires. And I'd just like to thank David for starting such a wonderful event. So thank you.